thank a lot of people for coming, and I will forget some, but Mrs. Michelle, our board chair, at the back there, several ministers, excellencies from various missions around, mission colleagues, Martin Chungong from the IPU, and normally it's characteristic to do thanks at the end for the organising, but I'm going to do it at the beginning because classically people naturally have lots of things to go to. So I really wanted to thank a lot of people who brought this together, including Amy Bolzas, sorry Amy, I'm mangling your name on a Sunday morning, Amy from FCI, Alana, and lots of volunteers. There's 17 volunteers got up on a Sunday morning from World Vision, from White Ribbon Alliance, FCI, and probably some I've forgotten. So sincere thanks to all of you, because these things don't just happen, as we know. I'd also particularly like to thank the high-level speakers coming, the high-table speakers. Dr. Margaret Chan, Director General of WHO, needs no introduction. We will know she's extremely busy at the moment, so it's very much appreciated that you're here. Dr. Richard Horton, editor of The Lancet and co-chair of the Independent Expert Review Group. Farida Luyingo Mwanje of the White Ribbon Alliance, thank you very much. Bob Orr, Assistant SG of the UN, responsible for Every Woman, Every Child. We've done this now, this is our third year, to really set the stage on progress on women's and children's health. We do it at the outset of UNGA so that we go into the week with a clear picture of what are our goals and how we need to steer together. This is a very critical time. We've got less than 500 days now, increasingly intense discussions on the SDGs. You can look in your packs, so there's a pack here. We've got a consensus statement on the post-2015 environment, which thanks to a lot of you, has now got the weight of 300 organisations behind it, and we're lobbying for many more signatures because we hope as people go into the discussions on the SDGs, with all your energy, women and children really are going to remain at the centre, and the important agendas we have on reproductive, sexual health and many other things which need to be fully embedded in human rights remain there. So we've got a crucial window on women, children and adolescents being at the centre. And we now know from Success Factors, many other studies, that I think it's called the health enhancing sectors, are really, really very important to what happens to health outcomes. So we're going to hear throughout the morning on the progress on Countdown, on what the Independent Expert Review Group has found on the PMNCH report, exactly how we can move forward together in this post-2015 space. And it's also a very good time because I think one of the hot topics, looking around at Tim Evans and others with no particular agenda, there's a lot of discussion on a global financing facility for women's and children's health. So this is the place where we want to kick off a lot of those discussions, hear what you think. The technically literate of you can be tweeting throughout the event on these hashtags here, Commit to Deliver, MDG 456 Live, and the others that are underneath there. So please engage, be active. We'll try and leave a lot more time for discussion than we've sometimes had in previous years. Speakers will ask you to keep to time. Andreas is going to hold up in waiting 1-minute signs from time to time if you stray over. So to kick us off, I'd like to call up my co-chair Joy, to John Richard Horton, who presents the Independent Expert Review Group, to Dr. Chan on behalf of the United Nations Secretary General, and do some brief introductory comments. And there's a photo up here for you, and a photographer to take a photo.
Thank you so much, and welcome to everyone. It's a privilege to be here amongst the very, very committed me in the fight for good health and well-being of women and children around the world. Now, we in the iERG have been very, very privileged to work with countries, ensure that all of us step up to the plate and play the role that we have committed ourselves to play to ensure that every woman and every child is given access and enjoys the right to good health and well-being that are entitled to as human beings. And this process, we would like to emphasize very strongly We are not doing these women and children a favor. None of us are. We are simply playing the role that is expected of us. And because we are simply playing a role, it is totally unacceptable that where it is preventable, where we do have the capability, where we do have the wherewithal, the resources, the technical capacity, and the technical ability, that any child, any woman, any adolescent should suffer ill health, morbidity, should die, because we can avoid it.
Thank you, Joy. Friends, colleagues, this is the longest report we've written so far, but there are only 4 messages that we want to pass on to Dr. Chan and colleagues. The first is that the past year has seen unprecedented progress. But that progress, let no one say, equals absolute success. Second, we have seen remarkable advances, but those advances conceal still huge critical gaps for women and children worldwide. Third, what we see in the future are incredible opportunities. But again, those opportunities hide unacceptable, indescribable suffering for tens of millions of women and children around the world. And finally, what we have before us is a prize that we can take with both hands, but only if we truly understand the meaning of the word sustainability. The possibility of ending preventable mortality for women and children requires us to understand that the word sustainability means that it's about all of us, not a few of us. It's about paying attention to the future women and children as much as to women and children of today, intergenerational equity. And it's about recognizing that sustainable growth is not necessarily the same as maximum economic growth that we have today. And we have to critically examine our political, our economic and social systems to ensure that we are truly delivering for women and children worldwide. And if we can, the prize is great. So on behalf of Joy and the rest of the independent expert review group, it's my pleasure to present our report to Dr. Margaret Chan, Director General of WHO. Dr. Chan.
$10 a piece, huh? Okay, thank you. Thanks for this.
Dr. Chan, can we invite you to the podium to do your remarks?
Oh, okay.
Unless you want to go.
No, I'm okay. I can stand up. Thank you. Distinguished panel members, so many old friends and new friends in the audience, good morning to all of you. I was actually quite struck that so many of you are here before 8:30. That tells me how important this meeting is to you, and especially the topic. I'd like to reinforce some of the points that had already been made by the previous speakers. What do we mean by accountability? What do we mean by sustainability? And of course, the topic of today's discussion is extremely important. Leave no woman, child, or adolescent behind. Indeed, the post-2015 debate is all about leaving nobody behind. In order to do that, that means we have to be very inclusive. We have to include everyone. We need to take a life course approach to make sure that is inclusive. Of course, paying particular attention to women, child, and adolescent. But I insist, and I hope you would agree with me, the life course approach is important. Otherwise, you leave someone like me out. I'm 67, so I'm not qualified for adolescent. Oh, Agnes, so good to see you. You look so pretty, I couldn't even remember, almost didn't recognize you. And Carol, I want to congratulate you. I see a young person in this meeting. In previous meeting, I did say, where is the youth? Thank you. Thank you for bringing young people into this meeting. As I said, in order to step up to improve the results even further than those that has been reported by the iERG report, we need to do much better. The World Health Organization launched 2 new reports that can guide our collective action. The first one was the detailed action plan for every newborn. And the second one was WHO's first report on the health of adolescents, the 2 groups that are covered by the title of your meeting. Now, of course, we all remember history. At the beginning of the MDG, progress in maternal health especially was slowest. And that's why Mr. Secretary General took upon himself to re-energize the support for women, children, and newborn, of course, including adolescents, by branding an initiative called Every Woman, Every Child, which is very familiar to all of us. And flowing from that, we have set up a multiple of commissions to look at transparency, accountability, to look at the importance of commodities. And that brings us to some of the good news because of your generosity, your commitment and action. Now, Richard talked about the excellent progress, and let me just share one thought with you. That kind of progress can be extremely fragile. You look at Liberia. Before the Ebola outbreak hit Liberia, that country was showing one of the most acute drops in maternal and child mortality anywhere in Africa. Now, with the country's health system shattered and nearly all capacities shut down, no health services at all are available in the city, especially in Monrovia. 70%, 60 to 70% of deaths are women. Why? Because women play the very important role of mother, grandmother, carer, and they get to do, the home, at home they take care of the loved ones when they get sick, and to respect the burial practice, they get to wash the bodies. Those are extremely high risk, and so many of them gave their life in serving their families and communities. So that reminds us the excellent progress made can be so fragile. If you don't have a strong health system, this is our strong belief, you cannot withhold the shocks that come your way, be it cholera, be it Ebola or malaria or something else, NCD. All these are important issues that we really need to pay special attention to. Accountability. Accountability is important, but especially important at the country level. We must, and we depend on you, civil society friends and colleagues, hold governments to account. We must do that, leaving nobody behind, while only a few, the powerful and the rich, get all the benefit. Without these structures, health system infrastructure, healthcare workers, good health information system, and including accountability and transparency, no country is stable and no society is secure. No resilience exists to withstand the shocks that our 21st century world will continue to deliver to us one after the other. So friends and colleagues, let me finish by saying how pleased I am here year after year just to join you, to show our commitment, to celebrate our success, and yet not to be complacent with all the challenges ahead of us. Post-2015 development agenda, 4, 5 years, and must be center stage
Thanks so much, Dr. Thanks very much, very much. You are the collective action in the right way, in the right place, the right time for every woman and child, regardless of social economic status, regardless of what tribe or religion they belong to. We give their life, bring life. And now in crisis, they are giving their lives to service humanity. Surely this is more than enough. It is time we save them. It is my honor and privilege to invite a very, very important contributor to our commitment meeting here this morning. And this is Ms. Farida Luyuga Manje of the White Ribbon Alliance for Safe Motherhood in Uganda. And she's going to share her perspective, a very important perspective of a young woman on what this is what we should be doing.
Good morning, ladies and gentlemen. My name is Luiga Farida Mwanje, and I come from the White Ribbon Alliance for Safe Motherhood in Uganda. I'm here as an advocate, as a citizen of Uganda, as a mother, and as a sister. Last year, my sister died in childbirth at a private facility in Uganda. She left behind a devastated husband and 4 children. Her baby survived, but he suffered brain damage. My sister bled to death, and there was no blood to save her life. It is then that I realized, if this level of neglect can happen at a high-end facility in Uganda, what is happening with childbirth for most of my country women in Uganda? I joined the White Ribbon Alliance for Safe Motherhood, where I'm campaigning to make childbirth safe for women and children in Uganda. I'm happy to be in New York, and I thank the Partnership for Maternal, Newborn and Child Health for this rare opportunity to speak about the work we are doing with families, with communities, with district officials, with health workers, most especially midwives, and with politicians. It is a rare opportunity because of the challenges we face in being heard. Many of my colleagues were invited here, but they face challenges of funding, visas, and language barriers. But I want to speak for them and tens of thousands of other White Ribbon Alliance members who are doing all that they can to make a difference in their countries. I must say that every woman has a right to good quality and respectful maternity care, and it is a responsibility of the government to fund the provision of this care. My government, that is the government of Uganda, committed that the global strategy for women and children's health to ensure that half of health centers provide life-saving emergency obstetric and newborn care. But research done by White Ribbon Alliance in Uganda shows that none of these health centers can provide comprehensive emergency obstetric and newborn care. This research was done by community members, district leaders, and health workers. And for the first time, it brought together all these groups of people to work as partners without any fear of being blamed. We brought together the community because they need to know their rights and demand them. We're working with the health workers because they need support, training, good pay, and good working conditions. We're working with the district officials because they're keen to help when maternal health is seen as a priority. That is why I say to you today that we need to invest in grassroots advocacy and accountability, because it is a more sustainable and fastest way to lead to change. In the last 500 days, my government has been held accountable. We've been able to convince the government of the Republic of Uganda to increase the salaries of health workers. And recently, the government announced a 13 to 18 pay raise in the salaries of health workers. And this is a very big incentive for them to stay in post and a boost to their morale. And by the way, this is happening at a time of very serious cuts in the health budget. Health centers are being renovated. There are more supplies, and there are more health workers being put in post. And this is what we need to do to save the lives of the 17 mothers who die in Uganda every day, including my own sister, Remi Wamala. I must say to you now that none of us understands the value of lives of mothers lost during childbirth. It is only our many orphans, and widowers who know the true cost of a mother lost, and they will tell you that these lives are priceless. That is why we need to invest in women, and women and their families have a right to this investment. I therefore call upon you to invest in the citizens who are doing all they can to bring about the needed and wanted change in our communities. I want to thank the leaders at this forum who have given their space for the citizens to be heard. Thank you so much. We asked and you listened. To learn more about the impact of White-Born Alliance, please get yourself a copy of the Citizens Post. Thank you.
Thank you very much, Farida. You have challenged us. Accountability leads to effective, sustainable gains for women and children. We must never forget that. And it is my honor now to invite the Assistant Secretary General in the UN Secretary General's office, Bob Orr. We are here today because the UN Secretary General decided to energize us and to motivate us to be more aggressive in how we respond to women and children's health, because women and children cannot wait. Bob Orr, can you please come and share with us your experience in the last 4 years since the Secretary General launched this important movement?
Thank you very much, Joy, but especially thank you, Farida, for reminding us exactly why we're here. Your sister, her family, that is why we are here. My friends, the world is a mess. The Secretary General this week is focusing on more crises in more places than at any time in history of the United Nations. The stresses on the system are palpable. The challenges are at a scale that sometimes overwhelm. There is so much wrong in the world. But my friends, what is right in the world is what is in this room. This movement that you have built painstakingly, personally, with investments of time, of your treasure, of your organizational time, all the leadership in this room is impressive. I do remember when it was about 5 people in a room. And Margaret Chan is nodding because she was one of those 5 who remembers this was just an idea a mere 5 years ago. An idea that all the work that everyone was doing was important, but it was nowhere near enough. We weren't working together like we should. We weren't investing as much as we should. And yet we all knew everything begins with mothers and children. Everyone said this was our priority, and yet it was at the very back of the MDG train. The Secretary General had a very simple insight. He said, if everyone can agree that mothers and children should be at the front of the queue, at the front of the MDG train, how can we leave it at the back? I want to call together all the people working in this field. I want the UN system to lead. I want all of our partners to come together. I want a global strategy. I want a plan. I want to know what we're going to do. And of that simple vision was born an initiative. But this is so much more than an initiative today. It is a movement. You have created a movement. Things are happening not just under the banner of Every Woman, Every Child, but because of Every Woman, Every Child in places we don't even know about. That is exciting. So from one of the people that was in that room in the beginning, a total layperson, not one from your community, I tell you, you have inspired me. You have inspired the Secretary General, and you are in charge of a global movement that is succeeding. There is so much left to do. But in a world that is a mess, you show a model. Stay together, stay strong, stay accountable, keep up the investments, and you will continue to inspire. The Secretary General appreciates everything that everyone in this room is doing. I thank you very, very much.
Mr. Assistant Secretary General, thank you very much, and thank you for your leadership, and for the motivation, and for your inspiration. You are right. There's been a lot of progress, but the gains that we have made in a lot of our countries are fragile. And Dr. Chan just spoke about how fragile they are when she talked about the sad loss and the sad regression that we're beginning to see in Liberia because of the Ebola crisis. So we must sustain the momentum. We have to continue this fight, and we must be more aggressive than ever. Thank you so much for your leadership and your inspiration. Colleagues, it is my pleasure to invite our very, very hardworking panelists to their breakfast. We have reserved a table here for you, so please come down and enjoy your breakfast. And thank you so much for this very, very effective opening session of our gathering this morning.
So while we have the transition, I'll invite the second set of panelists to take the stage. Miki Chopra of UNICEF and co-chair of the Countdown. Dr. Luis Huicho of the Universidad Peruana Cayetano Heredia and National Institute of Child Health, Peru. Dr. Peter Berman of Harvard for the Financing Working Group, a Countdown to 2015 group, and Ms. Diane Giacovella, Assistant Deputy Minister, Department for Foreign Affairs and International Trade, Canada. And I'd like to point out, because Dr. Chan mentioned young people in the room, we have a set of journalists that we have supported to come to this meeting. If you could wave your hands if you're one of them, but I think you're all relatively young as well over there at that table. And we really hope that the reporting, the messages getting out, like Bob said, will be out there around the world for all to hear, so that this energy that he so rightly highlighted remains and gets carried forward by the next generation. So are you all seated? Yes, you are. So, Miki, I think you're the first.
Yes.
And, I should have said, we launched this report in Johannesburg. At that time, we didn't have hard copies, I think, but today we do have hard copies, and it's one of the reports, as you know, Countdown to 2015, which is most referred to by many, many actors. Go for it.
Thank you. Good morning, everybody, and it's great to be back, and we've done this now for a number of years together, and there's always two observations that people always have when they come to me afterwards. They always say, this has been the best session because we've always had data and evidence, which is a real refreshing change from the rest of the week. But then they say the second thing is that, like the rest of the week, we never keep to time, and we're always running late. So as Tees pointed out to me, I have 1 minute to get us back onto time. So I will speak quickly because I think many of you are familiar. The report is now out in hard copy, and I hope you've picked one up. So my task this morning is really just to give you the broad highlights and really leave the real work to my colleagues who are going to talk about specific case country example in Peru and this kind of work that we're now doing in more and more countries, as well as the important thing that you're all most worried about, which is the money as well. So this is a graph which I hope you're all now very familiar with. It's our sort of signature graph, if you like. And the reason we're we always keep coming back to this is for two reasons. One, because it's quite pretty and has lots of different colors and looks quite attractive. But most importantly, it captures the bringing together of our different communities. It captures this continuum of care that we've consistently spoken about and which we're now starting to see translated not just in terms of wonderful graphs, but also in terms of our actions and our interventions as well. And it also reminds us of particular interventions and particular groups in particular who get left out year after year. And one of the main objectives of our annual reports is to try and pick up and highlight key groups and key countries and key interventions which we feel have been underemphasized and are lagging behind, and therefore lagging progress for the rest. We focus on coverage and coverage of critical interventions, and that's important not least because it is, at the end of the day, very closely related to the kinds of the key results we want, the saving of lives of women and children. And as you just heard from the previous panel, this literally is the difference between life and death. Having blood in the hospital, having a skilled birth attendant is the difference between life and death. But we also have recognized, and this has been a theme which, thanks to in particular the work of Pilates, colleagues from Pilates and Cesar, really focused as well more recently in the last few reports on the equity dimensions. And not only in terms of data, but also the way in which we present that data. And here is a graph which I hope you're all now getting more familiar with in terms of looking at how we can show the difference, the persisting difference between the rich and the poor. And how just closing that gap, even within countries, we could save millions of lives just by doing that one action. So that's been an incredibly important theme running through our reports, and one which we now, it's good to see becoming more mainstream in thinking and talking about progress. But we're not just focusing on the critical interventions. We do also, in the countdown, look at some of the aspects that lie behind and the important determinants that lie behind coverage. The graphic is small, but there are things such as policy shifts, whether a country has maternity protection, for example, here. So we are monitoring critical policies and legislative determinants which we know are critical for seeing policy shifts and coverage changes as well. But we've also recognized that underlying coverage can also be things which make it more challenging to achieve improvements. This is an example of the number of births and the cohort, if you like, and showing how just the issue of fertility control and management and giving women the right to choose contraception and so forth can play an important role for both in terms of making progress and increasing coverage, and just how the numbers sometimes we forget about as we look at rates. Here's an example from Pakistan showing how the increasing numbers with a flat rate of coverage, number of births, means that the number of deaths has actually increased in Pakistan over this period of time. And we have at least 2 to 3 dozen countries where, despite progress in coverage rates, the numbers of deaths is increasing. So we mustn't be fooled by changes in rates and coverage or even mortality rates, not just because of the reasons that Dr. Chan outlined, the fragility sometimes of this progress, but also not to forget the numbers, and the numbers of children and women are changing as we speak. I want to shift slightly now towards some of the principles that underline countdown. And the reason I want to do this this year is that it is the countdown to 2015, and it's now the end of 2014. So we are starting to think about and reflect upon the lessons we've learned as the countdown to 2015, as well as what is the role of such a collaboration moving forward. So I just want to spend a few moments as I close up, just to share with you some of the reflections of the group moving forward. The first point to make is that data and evidence remain absolutely essential, and we're not done enough. This is just a graphic of some of the surveys that have been done, household surveys showing the different years of these surveys. And as we approach the reporting on the MDGs later this year and next year, it's important that we reflect that we still continue to rely upon expensive household surveys, which only reflect what's happened 3, 4, 5 years in the past. So we still have immense challenges that much of the key data that we need, the graph there just shows the COIA indicators that still a majority of countries are only regularly reporting on only 1 or 2, a minority of indicators which a group of experts recognize as the most critical for monitoring progress. So our investments in health information systems, which is a core part of health systems, and in many ways the canary in the mine of health systems, the strength of health systems, remain woeful. Data is critical because it's linked to accountability. And so one of the important steps that I think the Countdown to 2015 has made has helped the community to define what types of data and what quality of data is required. The COIA and the Commission for Accountability was a critical step in that process of helping the community to identify critical pieces of work. And through the leadership of TEAS and WHO, we've more recently now been able to also define more broadly critical indicators for countries. So great steps forward in that sense as well. But data in itself is not sufficient. Evidence in itself is not sufficient. It does require the packaging. The COIA and the Commission for Accountability was a critical step in that process of helping the community to identify critical pieces of work. And through the leadership of TEAS and WHO, we've more recently now been able to also define more broadly critical indicators for countries. So great steps forward in that sense as well. But data in itself is not sufficient. Evidence in itself is not sufficient. It does require the packaging and making it understandable to people who are not technical and technicians or doctors and so forth. It needs the politicians, the policymakers. So we need to package it and put it in a format that people can understand and make the messages clear and able to be understood. But most importantly, we need to bring a collaboration of the academics, civil society, as well as the people who are producing the data, so that we avoid confusing policymakers and others with public clashes around which indicator, definition of indicators, data sources, and so forth. It's one of the key lessons that we have learned is that when we've gone into those sorts of internecine fights, we've sort of done huge damage to the movement. So the Countdown has been an important forum for bringing together these different constituencies, for allowing us to have in a very dispassionate forum in which we can debate and discuss the critical indicators, where we can discuss and debate what the data sources and how good or bad those data sources are, and where we can put out key messages behind which we can unite and push forward on. So moving forward, we do think that there is still a need, and if not an increasing need, for this sort of collaboration, for this focus on accountability, but accountability based upon data and information, which brings together the different constituencies in the manner I've just described. We do feel the focus on equity needs to be deepened, that one of the key lessons we've learned from the MDG targets was the lack of equity within those targets has meant some slippage in terms of countries feeling though they made the progress and they're achieving the MDGs, but they may well be doing it by leaving large proportions or substantial minorities way behind, and we don't pick that up as quickly as we should be. So equity and data and targets, we believe, still should remain a core part of the post-2015. And as I've been mentioning through my talk, the investment in health systems, as manifest by health information systems, needs to remain a core message moving forward, regardless of the targets which are selected and the goals which are put forward. And finally, as we've heard today, this morning already, we cannot wait for a new set of goals before we re-energize and refocus ourselves. We have a task still to be completed. And by further doubling down on these MDGs, we can create the momentum, an irresistible momentum, to make sure that women and children remain at the heart of any post-2015 goals as well. So I just want to thank you, and hope you will pick up the reports, because there's a lot of detail and depth and case studies in that report, which I've not been able to reflect, but hopefully will be picked up as well. Thank you.
Thank Thank you very much, Mickey. We've had lots of memorable moments in these brunches, but I think people often go away very much with the country case studies in their mind. So I'm very pleased that our next speaker, Dr. Luis Huicho, is going to talk about the Peruvian experience. We've had countdown case studies which have been published on Niger, Bangladesh. There's one shortly coming on Tanzania. They're in your packs, the first two. And we're here today about Peru. So, Dr. Huicho, please. Thank you.
Good morning. I'd like to share with you a summary of preliminary findings of the Countdown Peru case study, a research effort that aims to show how Peru achieved a remarkable progress in reproductive, maternal, neonatal, and child health in the last few decades. Let's say first the time trend and the equity aspects of the impact indicators. Clearly, technology. It's empty. Thanks. Clearly, maternal, neonatal, and under-5 mortality all declined significantly from 2000 to 2012, while under-5 stunting declined, especially after 2008. What happened to progression of impact indicators over times when considered by worth quintile? Clearly, equity is improving. You can see that decline of mortality and stunting has been greater for the poorest quintile than for the richest one. Although, of course, there is still a gap that needs to be closed. So, sorry, but I'm struggling with this issue. So, starting declined, the equity gap was closed, and what happened to progression of impact indicators in terms of social trends? Poverty and the rural population have declined sustainably. Total fertility rate has declined. Women's education and families with access to improved water has increased over time. And all these changes were supported by strong economic growth and enabling policies. For instance, per capita GDP has more than tripled from 1990 to 2012, while the Peruvian Conditional Cash Transfer Program, which was introduced in 2005, has scaled up impressively over time. What policy changes happened outside and inside the health sector? Basically, policies of social assistance, poverty, and alleviation fertility reduction were adopted by different governments in the 1990s. While in the 2000s, civil society and other stakeholders pushed the adoption of long-term political commitments and the consequent adoption of anti-poverty, better anti-poverty policies and resource-based and performance-based cross-cutting policies aimed at improving the performance of public health sector, particularly the education and health sectors. These policy changes were translated into actual implementations of different programs in the 1990s, such as the Family Health Program, aimed at reducing fertility, food supplementation programs to improve food security, and health system strengthening programs that attempted to increase the access of poor people to health services. In the 2000s, anti-poverty programs such as the Conditional Cash Transfer Program, Juntos, were implemented, and also the Comprehensive Health System Insurance System that was introduced in 2002 extended the access of poor segments of the population to health services. At the same time, more emphasis was paid to promote culturally sensitive health services like the vertical delivery for native communities. And more recently, cross-cutting, result-driven maternal and child health programs were implemented, such as the Coordinated Nutritional Program and the Maternal and Neonatal Health Program, aimed at reducing under 5 stunting and further reducing maternal, neonatal, and child health mortality. The health system has been serving progressively more children, as it is shown by the number of 105 attendances since implementation of the comprehensive health insurance system started in 2002. The health system has also invested in cross-cutting, results-driven maternal and child health interventions, and you can see that the per capita expenditures of nutritional program and maternal and neonatal program has increased substantially over time. The health system, what about the changes in specific reproductive, maternal, neonatal, and child health interventions coverage and equity? Coverage of family health program has leveled at 90%. Coverage of maternal and newborn health interventions such as antenatal care visits and skilled birth attendance has been increased, again by reaching the poor and closing the equity gap. It's clear that the increase in coverage for antenatal care visits and skilled birth attendance has been greater for the poorest quintiles than for the richest ones. Although coverage for child disease treatment such as care seeking for pneumonia and oral rehydration therapy for children with diarrhea still needs further improvement. Overall equity has improved, as you can see in this figure for composite coverage index, which has improved more for poorest segments of the population over time. So how did Peru do it? What's the story behind the Peru's success? Well, thanks to a combination of factors. Through improvement of key social determinants of health and through increase of coverage of specific maternal and child health interventions. And thanks to strong advocacy role of civil society, which was instrumental in pushing the adoption of long-term political commitments, which were translated into better pro-poor and cross-sectoral implementation of out-of-health sector programs and of specific maternal and child health interventions. And the efforts were sustained over time across governments and spanned several years, ensuring in this way the lasting progress achieved. Peru is now facing new challenges, and it's working hard to face them successfully. But I think that's quite another story. Thank you very much.
Thank you very much, Dr. Luis. I won't mangle your surname again. We have a few minutes if people want to ask any questions, not just of the last two presenters, but just generally, and maybe addressed to anyone who's here, because I know some of our speakers have to go shortly, and before we get to the next segment. There's a roving mic, apparently, and I see Carmen already and Zulfi, and I'm sure there'll be others. Who's got the roving mic? Okay, it's over here, please go. Run, run, run. It's Carmen at the front, red top. Just talk loud, Carmen.
Okay. Okay.
Test.
Thank you very much. Very interesting panel, and specifically about what Luis presented, I want to call your attention to the fact that the iERG also conducted a mission to Peru this year. Catherine and I went there with Paul Hunt and a group, and we confirmed many of the points made, but I think Peru has very important lessons for other countries too, and I would just highlight our whole report is in here in the big version, not in the summary version. But we found two things that I'd like to stress. One, that you mentioned the role of civil society that is now underfunded, and the MESA, the Ouvidoria, which is not civil society, but the accountability mechanisms there need reinforcement, need supporting, and the international community needs to support accountability per se in order to advance women's health and children's health. The other thing is the political will. There's a lot of political will in Peru regarding child health. But reproductive health is neglected, and our report highlights many, many instances of violations of reproductive rights and also of neglect of promotion of reproductive health.
Okay, maybe we'll take a couple of comments and then ask. I saw Gary, Zulfi, so maybe, okay, you're closest to Zulfi. There you go. Could you introduce yourselves? Because I think we all assumed everyone knew who Carmen was, but and we do. But
all right. So I'm Zulfi Bhutai. I'm one of the co-chairs of Countdown and have worked in this space. So I have a question for the panel in general. I mean, these data and the progress are remarkable, encouraging, but they're at the same time also humbling in some ways. So we heard from the DG this morning of how Ebola has, for example, completely disrupted remarkable progress in one geography, and there are many other examples. So is conflict. And what I would like to ask the panel in general is, how do we ensure that in our messaging to countries and to implementers, that we are able to introduce the concept of social safety nets and the protection for MNCH programs in countries builds in the buffer for these uncertainties. These are things that no country can predict per se, but they are huge issues in terms of scaling up of interventions and indeed the health systems, strengthening that we consider so integral to MNCH. So in other words, what is our message to people out there around the whole issue of building in sufficient buffers within our MNCH programming, our immunization programming, so that these uncertainties can be taken care of? Thank you.
Thank you, Zulfi. I saw Gary.
Thank you, Carol. I just also, as Zulfi would say, so many of us are spending so much of our time now over the last several weeks, I'm Gary Cohen, by the way, on the response to the Ebola outbreak and trying to support the agencies and organizations that are fighting this on the front lines. This is the observation I want to share. So this breaks out on the border of 3 countries, all of which are vulnerable, 2 of which were post-conflict. The health system collapses, and now there is also to some degree a collapse in civil society. And compare that against other countries. Nigeria got the outbreak under control very quickly. And I think that the investments made in the HIV/AIDS response since 2002 or so enabled health system strengthening to occur in countries supported by PEPFAR and Global Fund that did not happen in the same way in West Africa. So the question is, what can we do as a global health community to help support the fundamental health system infrastructure to not allow us to be so vulnerable to an outbreak like this that should have been controlled and is still spiraling out of control, much worse than the news media reports?
Thank you. I think I'm going to have to close off after Priya, Honourable Minister, Anders and Dean Jameson.
Who was first?
Sorry, next was whoever I said. Priya, down here.
Thanks. Priya Agrawal, Merck from Others. Comment on Miki Chopra's presentation. Thank you very much. There's 2 things that really stood out to me was the fact that we need a data revolution, or at least at the minimum evolution, and the second, the importance of actually ensuring that we don't do a data dump on the community and we have clear messaging. I was wondering what we're doing as a community and whether there's a call to action in terms of interacting with the technology folks. So I know that some countries have introduced continuous DHS, but is there a new way we can be getting the critical data to make this report real time?
Thank you. Honourable Minister.
So thank you. I don't have a question, but I agree with you, and I agree with you. Data are key. And we can have it on real time. We have had that. In Rwanda, when a woman dies, I have to be informed in the morning. The name, the reason, and why. And now it's so strong that even the medical and the nursing council have taken it over. There is a survey to see if there were no negligence. And the other thing, the question there, don't try to build a health system in the middle of the crisis. What happened in my sister's countries? There were the countries, it's not PEPFAR or Global Fund, it's everybody. The countries who had the health systems manage it. The country who didn't have a health system, the little they had collapsed. So there is an accountability we should think about in this room, because the funded are here. What are you paying for? And you are accountable for that. The money you have given in parallel of health systems that didn't build the health systems as a result of Ebola. You need to build a health system. And if you don't believe you build something. I think this bell have to bring you back in your office, in your thinking, in your ethic behavior. Build for sustainability. Invest in future. Not giving money like that to please because it's sexy at this time. So this was my contribution.
We're going to have to close up this segment shortly, but Anders, Dean, and Miriam, then really we have to move on. And I think we won't get panelists' responses because we'll take it to the later part of the session. But Anders, quickly.
Thank you very much. I'm Anders Nordström from Sweden. Data is for management, as the minister was illustrating happening in Rwanda. Data is for accountability, but accountability is about holding ourselves accountable, making sure that we actually use the data in order to improve management, to improve efficiency. And that's a little bit my question here. How are we doing that at the national level with the different key stakeholders, both a clinic, a hospital, a health center, but also with civil society and private sector in countries, but most importantly, not most importantly, but also important at the global level, the global health architecture, the global health system. Are we using now this data actually to push ourselves to make the system work even more effectively? Making sure that the different bits and pieces of a system is doing what it's supposed to do at the best possible quality. Because this is what it should help us to do in a positive way, not just saying what is not working, but also ensuring that the different players in both the national system and a global system is really doing its work in order to be able to maximize the effectiveness of those resources. I'm absolutely convinced that we can do better than what we're doing today, but then we need to have an honest discussion about that. Thank you.
Thank you, Anders. Dean is right over that side, Gear, so more running. Quick, you're a fit guy, you go running, quick.
Good morning. I'm Dean Jameson from the University of California in San Francisco. I have a comment about the slightly larger context of our work on RMCH, and in particular prompted by the Director General's observation that there are people over 60. I would observe that there are indeed in this room people over 70, and that as we develop our goals around RMNCH, around child mortality and maternal mortality in particular, in the context of the development of the SDGs, I wanted to call your attention to and ask consideration for a paper published 2 days ago in The Lancet that calls for an overarching goal on mortality reduction that has strong and specific goals for maternal mortality and child mortality, but does that in the context of goals for NCDs, injuries, and reduction in mortality, essentially at all ages, as the SDG calls for. The rubric is 40% by 2030. The concept is to reduce by 40% the number of deaths that would occur in 2030 if mortality rates continued unchanged from 2010. The implications for child mortality, to take that example, in the low-income countries would be to reduce child mortality by 2/3 to a level of about 34 in the lowest income countries, on average to around 20 or so. The child mortality and maternal mortality goals fit well into this overarching 40% by 2030 goal. And what I'd pose for those of us that are particularly concerned with RMNCH is that it may make sense, and I pose this as a question, to integrate our goals with that larger framework. Thank you.
Thank you, Dean. And before moving on to the next segment, we've got two ladies who did wish to speak. So Miriam, very quickly, and our Liberian colleague at the front. And then we'll move on.
Thank you very much. I think that as we move forward to post-2015, it's important that we consider community health systems, because where there are very low coverage of health services, without the community system, we cannot have either coverage, nor can we have strengthening of social safety nets. So going forward, I think we need to address the issue of how do we address community establishment of community health systems that are strong and that can support every woman, every child. Thank you.
Thank you. And the last comment, lady here in the green. Please introduce yourself.
Thank you and good morning. I'm the Minister of Gender and Development from Liberia. I just want to add my own voice to my sister and doctor that spoke earlier. We're talking about women and children, every woman, every child. Liberia was a conflict country. Liberia is a fragile state. And now with Ebola, it's even worse. Prior to Ebola, Liberia was on the verge of meeting one of the most important part of the Millennium Development Goal. And Joy can attest to that, it's in the book. But now what has happened to us in Liberia? 75% of the people affected with the disease or have died from the disease are women. Pregnant women now in Liberia, there's no regular healthcare centers because most of the centers are being used for Ebola treatment. We're having problem getting them time enough to a facility that can help them. So we are losing a lot of them. In the early stages when they are pregnant and the virus gets into them, it pushes the fetus out. So it's a serious problem now trying to care for women and children. Since July of this year, our schools have been closed. I agree with my sister when she said, don't build a facility during crisis. Build it prior to. And then during the crisis, you can test the strength of the facility. All of our facilities right now are at a standstill. We have come to join and say thanks to WHO, UNICEF, WFP, the US, all of our partners who have joined us. The sooner we can stop the spread of this disease. There have been some good news. A lot more people are walking out of the treatment center now healthy. That's what we want to do. Our goal is to stop the spread of the disease. To start curing people instead of burying dead bodies. Thank you, and I hope that this global world, as you talk about healthcare, help us build a system. Get more doctors, more nurses. All of our nurses, especially the women, because they were the caregivers. We've lost a lot of them already. Thank you.
Thank you, Honourable Minister Cassel. And that's a very sobering note, I think, on which to segue. We heard from many of those speakers there, please don't build the ship while it's sailing, make the investments before. And so when we face these crises, we actually have a sound system in place. We have the monitoring systems to know what we're dealing with. And hopefully we won't have the tragedies we're facing today in the future. So I've captured some of the thoughts we'll take into the later discussion, but I'd now like to get to the next segment of the agenda, and it is quite a good segue because we're exploring trends in RMNCH financing. The Countdown annual reports on overseas development assistance have been followed closely over the years. And we were encouraged, I think, that even during the economic crises, we did see rising investment. And so the evidence of resources is underlining the value of the Every Woman, Every Child platform. And we hear from Peter, what is the trend? Where are we going? Are we going to be able to build these systems for the future? Peter.
Thank you very much. Good morning, everyone. When I took my oath of office as a card-carrying economist, I promised not to present any charts or graphs before 10 a.m. on Sunday morning. But because my colleagues already did that, I feel like I have been exonerated from that pledge, but I won't do too much. I'd like to present to you some of the results from the work we've been doing in the Countdown to track trends in RMNCH financing. This work, especially the work on overseas development assistance, is largely the work of a team at the London School of Hygiene and Tropical Medicine led by Josephine Borghi, who wasn't able to join us today. Before I get into it, I want to just share with you a couple of key summary takeaway points. Some positive, some not so positive, and some challenges. So on the positive side, our results clearly show that despite the faltering that occurred in the trends in ODA financing for RMNCH that accompanied the economic crisis, there is clear evidence of recovery and positive movement. And this is important given the commitments that were made in 2011. On the not so positive side, I think we do see that the pace of increase could be greater. And that the needs still outstrip the resources that are available. And in particular, there's a great importance to understand better the role of domestic financing for RMNCH. And so we do have a challenge, all of us together, to keep the pace of improvement going. And although money is not the answer to all of these problems, it is part of the answer. And we do need to keep our focus on that. Now let's see if I can make this work. Okay, so the countdown has been tracking RMNCH financing and particularly ODA since 2003. The work, as I mentioned, is being done by the London School of Hygiene and Tropical Medicine. I want to just point out that in the most recent years, we've introduced a new part of this measure. We've been tracking maternal and newborn ODA. We've been tracking child health ODA, that makes up MNCH. And more recently, we started tracking a measure we call R-star. R-star is basically the additional expenditures on reproductive health over and above MNCH. Now, I know this is a little different from the way things have been presented by other people looking at these questions, but it does allow us to continue to track MN and CH and the additional reproductive health expenditures. And the combined number is representative of RMNCH. We've also been tracking ODA, but now, of course, some of the reports on ODA that are maintained by the OECD include other donors that are not part of official domestic, development assistance, specifically the Bill and Melinda Gates Foundation. So this notion of ODA plus you'll see in the slides which follow. The method that we use is to actually review the project reports that are on file about each of these projects. These now number into hundreds of thousands of project reports. It's a major task to do this, but it does allow a kind of detailed understanding of what the purpose of these expenditures is according to the organizations that provide these expenditures. And one thing this does allow us to do is to include in RMNCH ODA some of the expenditures that are for general health system strengthening and other kinds of general support which are identified as being relevant for RMNCH. So the basic picture has been a relatively positive one, although overall ODA declined slightly in 2011 and then rebounded somewhat in 2012. The picture for RMNCH is a bit more positive to that, with some increases over both periods of time and an increasing trend in 2012. And I'd like to point out that the countdown report that Mickey showed us a few minutes ago includes the results only up to 2011, but that we are working on a publication now that will come out shortly, which will bring the results up to 2012. This also points out one of the data challenges we have. It's 2014, and we're now just able very recently to report on 2012 financial flows. So we do have a challenge there to improve the timeliness and the flow of information so that we can track these trends over time. This chart shows basically the trend since 2003. The taller bars for each year are the 75 countdown countries with the greatest burden. The shorter bars are the non-countdown countries. You can see in the most recent years the addition of the R-star to the MNCH, And basically, it's a figure of rising trend with that faltering that I mentioned in the most recent years and then corrected now in 2012. If we break down this RMNCH figure into its component parts, you can see the changes from our measures in 2011 and 2012. We noted in the report that there was a slowdown in MNH ODA in 2011. This has been compensated for with an increase in 2012. And overall, the trends are upward, except for this R-star measure. And I want to remind you, R-star is the additional reproductive health expenditure over and above MNCH. That has, our data show has declined slightly in 2012. This is probably due to some of the slowdown in spending on HIV/AIDS-related expenditures for women and children. The composition of spending in terms of who is providing the funding does differ for MNCH and R-star. You can see that in this chart, bilateral funding is a prominent and growing share of aid for MNCH, and that there's an even larger part of that when we look at the R-star, again, primarily related to the importance of HIV/AIDS-related expenditures in this R-star residual. I'm going to just skip ahead because I've been told I need to stick to time. If you look at the distribution of this spending according to countries, you can see that 10 countries in the Countdown 75 accounted for just about half of the total ODA for maternal, newborn, and child health in 2011. These countries are sometimes some of the larger countries: India, Ethiopia, Nigeria, DRC, and the other part of spending, the other half, going to all the rest of the Countdown countries. And if we look at R-star, a very different group of countries turns out to account for most of the flows, and this again is related to that HIV/AIDS related component of the R-star. So these residual R-star expenditures tend to go more to countries with a very large burden of HIV/AIDS. We looked at the question of whether aid disbursements are responding to need, and using statistical methods, we were able to find a reasonable association between the levels of need in terms of children and women and the levels of ODA flows. But if we look over time from 2005, 10, and 12, we find that there's not evidence that this targeting to need is increasing, and that this might be a question for further attention. As resources are tending to plateau to some degree, are we targeting resources to where they are most in need? I want to spend a minute talking about domestic expenditure on RMNCH, which is a very important part of the total spending. We shouldn't forget that in many countries, the largest share of spending on RMNCH is coming from domestic sources. The COIA process called for countries to report on domestic spending on RMNCH by source, which would help us to understand better what is the level of spending coming from domestic resources. Unfortunately, this is one of the areas where the news to report is not so positive. In the 2014 Countdown report, we noted that only 4 of the 75 Countdown countries are yet able to report fully on domestic spending, and 2 countries partially. Although the work is underway in a larger number of countries, 18 countries are developing these indicators and 25 countries planning them. So this is a big challenge for us going forward. We really need to look at RMNCH financing not from the perspective only of external flows, but we need to understand and we need to incentivize national authorities to support RMNCH much better going forward. And this is what we've done in the Countdown report this year for the first time. We've included an indicator on whether these data are being reported by country. And the results, as I mentioned, were not so great in the 2014 report, but now we have a means of tracking this going forward. And I pose this as a challenge to all of us to take forward now. The last point I wanted to make is that there are different methods out there that are being used to track RMNCH funding and RMNCH external flows. The Countdown is doing some work. I'm going to be followed by a report on the work that PMNCH did as part of the commitment tracking, and the Institute for Health Metrics and Evaluation has also been reporting on these flows. This in and of itself is not a bad thing, to have different groups using different methods and different groups of countries in their reports. But it would be desirable, I think, going forward if we have consistent messaging and consistent reports that we can share with authorities around the world. And I hope that's another one of the challenges that we'll meet better in the future. So overall, we see some positive news of a pickup in flows of external resources for RMNCH. We do face a continued challenge to track domestic funding, and of course it's domestic funding that's going to make the difference over the medium and long run going forward. We do see a trend towards increasing role of bilateral funding for RMNCH, and this could raise some concerns in the future about the volatility or changes from year to year, since bilateral funding is perhaps more subject to local political considerations than multilateral funding. And we are hopeful that we will continue to see now the upward trend of the last year grow into the future as we continue to address these very pressing needs. Thank you very much.
Thank you, Peter, for sticking to time, and as a non-card-carrying economist, I understood most of what you said, though you still slipped in the univariate ordinary least square regression, which you can explain to us later. So meanwhile, I have great pleasure in introducing Diane Jacovella, the Assistant Deputy Minister, Department of Foreign Affairs, Trade and Development, Canada. I think Canada's commitment both to the issue and to accountability is second to none, so we're very honored that Diane has agreed to present the PMNCH report on tracking the financial commitments to the global strategy. Thank you very much, Diane.
Thank you, Carol. It's really a pleasure to be here today. This is actually the fourth report, the accountability report from PMNCH, and what has become, I think, a tradition of having a Sunday brunch in New York. It's really appreciated because I think many of us come here and we're going to be running from meeting to meeting, from crisis to crisis, but we start the week remembering what this is all about. And everything that we are doing is about every woman and every child, and let's make sure that all of the different meetings that we'll be attending this week on different issues and crisis, we remember what's really important at the end. Yes, I need to also learn how to. Okay, Carol, I did the same thing. Feel better right now? It's which one? Okay. There's a quote in the report from the Secretary General from 2010 that I think is really important to look at again, because I think it really says what we've been trying to do in terms of accountability is essential. It ensures that all partners deliver on their commitments, demonstrate how action and investment translate into tangible results and better long-term outcomes, and tells us what works, what needs to be improved, and what requires more attention. And I think it's our responsibility to keep doing this and keep making sure that the investment we're making are sustainable investment. Our colleague mentioned it earlier today. We need to make sure that our investment are having actually results for people. And the strategy from the Secretary General also brought something very special when it created the Commission on Information Accountability that was co-chaired by President Kikwete of Tanzania and Prime Minister Harper of Canada, because it actually made sure that accountability was part of what we were doing. And the creation of the iERG to make sure that we every year look at how are we doing, and we all know that the group is often having some tough facts, tough recommendation to us, but I think we need it because it needs to, we all need to be held to account in terms of what's needed. I think the Commission also, one of their key recommendations was the importance of strengthening or creating civil registration and vital statistics. So we have the data that we need to be able to know what's happening and whether we are making progress. So I think those are issues that we need to keep always in our mind. I was saying that this is the fourth report. So the first one in 2011 told us that there was remarkable a number of level of commitments, that 80% of those commitments, in fact, were relating to strengthening the health system, which I think is the right direction, because we all said earlier on today that we need strong health system for many other issues. 2012 report was more talking about the financial commitment, estimating them at $58 billion, and listing also that in addition to money, there's also a number of commitments from policy, advocacy, and non-financial commitments that make a difference. 2013 talked to us about the fact that the disbursements were reaching a high level, but that it was area that required more support, and especially newborn health and adults and health. And again, we saw, in South Africa, the launch of the Newborn Action Plan this year. When we look at this year's report, we see that the commitment markers have almost tripled since 2010, from 111 to 300. And that the financial commitment have reached 60 billion. And one of the things I think that is quite interesting is the various stakeholders that are involved. And you can see, if you can read on the slides, like there's very different groups that are now participating in the strategy. We saw also that 60% of the funds have been dispersed, which is good, because one of the things we were saying in 2010 is make sure that you pay what you pledge. We don't want empty promises. We want people to actually deliver on their commitment. The report also shows us that family planning, immunization, maternal and newborn health, and HIV/AIDS are the ones receiving the most attention among all of the issues. The report shows us also that although the level of ODA has decreased in some area, as Peter had mentioned, the ODA to women and children health, in fact, is increasing steadily, and it was 6.8 billion, and it's an 11% increase since 2010. But the one thing that it is saying is, although this is great, there's still much more financial needs for countries. The report is also showing us that yes, there's more money, but it's not necessarily going to where the needs are the greatest. And that is a challenge. We do have some countries that have high mortality rates that are not getting the funding that they need. And that's something that, as a community, we need to look at to make sure that the most vulnerable get our attention as well. If we look at the key message from the report is that we are making progress, both on number of the commitments that we're making and the rate of disbursement. But as research said earlier today, progress doesn't mean success. And I think that's something we need to always keep in mind. It also shows that there's an increased number of partnerships. So we've been able to reach out to different stakeholders that we hadn't in the past. We know that the money is actually going to the high impact intervention, and that's really important. So we know what works, and we're putting our money where it works. But as I said before, is that some high burden countries are not receiving the need that they have. In terms of looking ahead, what we need to do, the report points us in a few directions. First one is we need to keep our efforts high in terms of keeping it high on the political agenda at the global, national, local level. And we all have an opportunity with the negotiation for the post-2015 to make sure that mothers and children are central in the post-2015 agenda. We need to continue focusing funding on cost-effective, evidence-based intervention. We need to better coordinate our investment to increase efficiencies and effectiveness. And I think on this one, there's a lot of work that we need to do to streamline, reduce burden, and simplify. And Peter, you were talking about the various reports and the various calculations, and we need to simplify our messages so people know exactly what we want to do and how we want to do it. And as a community, we also need to better coordinate our efforts so we simplify it for all involved. The report also points out that we really need to focus on increasing domestic resource mobilization. And I think there are different ways that we are exploring no, in partnership with the World Bank, the Secretary General will call an event later this week where we'll talk about how can we work together to increase financing and leverage more financing for developing countries. And another point that I think is really important is making sure that we build in the accountability in the post-2015. There's a lot of learning from the global strategy, so we need to use those to influence what the global accountability framework for post-2015 will be. So I hope that all of us, we can continue to making a difference, increase our resources, increase our effectiveness, and make sure that we all make this a priority in our discussion on post-2015. Thank you.
Thank you so much, Diane, and thank you for your commitment and for the exemplary leadership of His Excellency the Prime Minister, and for the people of Canada's support to women and children around the world. I now invite the panel to return to your seats. Maybe you could enjoy your orange juice if you hadn't, after the first part of the breakfast. And I'm really privileged to invite our next set of panelists up to the podium. I will invite first one of my favorite ministers of all time, Her Excellency the Minister of Health of Rwanda. Professor, please come up to the podium. And I would like to invite Ambassador Marik Winrocks of the Global Fund. Marik, please come to the podium. And a very dear friend, Anarudha Gupta of Gavi. Please join us. And another dear friend and colleague, Dr. Tim Evans of the World Bank. Please come up to the podium. I'll hand you over to the capable hands of Carol to direct your panel.
Thanks very much. While people are getting seated, part of my earlier show and tell I didn't have with me, but this is the statement I referred to on the post-2015 development framework, which PMNCH is trying to get commitment to, and many, many of you in this room, including the government of Indonesia, Professor Mullock and others, have signed up. I do note that the Lancet UK is not yet a signatory, so we shall redress that at the end. But the important thing about this, I think, is we know from the high-level panel, which our gracious chair, Madame Graça Michel, was on, that actually getting these signatures is very, very important when it comes to lobbying, to making a noise on behalf of women and children. So please, I urge you, if you can, if you're not a government that hasn't yet determined your position, please sign up so we can say it's 400, not 300. Okay, so thanks to the new panel for joining us. We're very delighted because of your unique perspectives on investment, and we've talked a lot already about what's needed, but for accountability, but also for greater equity. We've had some great presentations about what we're doing well and maybe what we're not doing quite so well. So we're going to do this as a sort of a Q&A session. I'm going to ask the panelists to be pretty brief because I think there's quite a lot of interest in the room to maybe have a bit more discussion. So I'm going to start with Tim Evans of the World Bank. We've been hearing an awful lot in the RMNCH community about this new concept, or not so new, but labelled the Global Financing Facility for Women's and Children's Health, which you, with the government in Norway, the US, and others have been talking about. So could you bring us on the same page? What is it? What's it intended to do? And what are the next steps in the discussion in 3 minutes or less, Tim? Thanks.
Thanks. So we will continue with the same level of efficiency of all the presentations this morning, I hope. First, let me say that the Global Financing Facility for Every Woman, Every Child is really trying to work with and build on the momentum that the Secretary General has created through this, I think, groundbreaking and pathfinding movement that started back in 2010. As a good Canadian, I would like to recognize that Muskoka G8 really preceded that important UNGA meeting on Every Woman, Every Child, and I think together they've really put us on a new trajectory for achieving the results that I think we are so supportive of. We had an incredibly important summit in Canada in May of this year. And at that summit, Prime Minister Harper, 5 years into the Muskoka Initiative, committed $3.5 billion towards the next 5 years. And in a breakfast during that summit with the Secretary General, there was palpable excitement. And the excitement was that there was no slowing down around this agenda. Rather, there was acceleration to the 2015 objectives and through to 2030. And I think that that is really what was very much the inspiration for saying, okay, how can we build on this momentum, this acceleration, to craft the financing dimension to it? And so the Global Financing Facility is a SSS investment. And the SSS is this. First, it's scaled. And against total need, which we think is somewhere in the range of $5 per capita, we need to begin to look at what is the combination of domestic resources and ODA, which is going to get us to fully scaled financing. Not just the trends in ODA, but against need, total need in every country, how well are we doing in terms of scaling up our financing for the RMNCAH agenda? Second S is it needs to be smart and smarter. We've gained a lot of experience in how to get better value for money. Better value for money with respect to getting to the neediest populations, better value for money for delivering with greater results efficiency. There's been a massive revolution in moving from input-based financing to results-based financing. These are indicative of how we can get the best yield on limited investments. However, it also means that we need to look at how to engage the cross-sectoral investments much more effectively. So this is the double X sectoral, as in the genetic, the chromosomal makeup, and focus on women. So how do we get to adolescent girls in school and embrace them as part of this agenda if we think that delay of early marriage and school finishing are importantly linked to that? There are all sorts of innovative ways in which conditional cash transfers to those populations are allowing us to get very good health results. These are results that are not achieved primarily through ministries of health, and therefore we need to put that on the agenda. The third S is sustainability. We need to embrace the 2030 agenda now. And that relates to the fact that many countries are moving from low-income status to low-middle income to middle-income status or upper-middle-income status. And that trajectory will necessarily change the nature of the relationship with ODA financing. So first and foremost, how do we put more emphasis on the public and private mechanisms of domestic resource mobilization and really support countries and governments to strengthen their institutions to mobilize against need, such that the ODA is not substitutional, but additional and catalytic towards those ends. That's the sustainable. Now, the two A's, the double A. First is accountability. And I'm glad that Deanne mentioned the importance of civil registration and vital statistics. Those are going to be the ongoing accountability because that allows real-time reporting of every maternal child event, birth and death. And unfortunately, we're woefully underfinancing those systems. And so we have been working with partners to look at how we can finance those. So again, those are not a financing vehicle that is found within the Ministry of Health. That is really looking across government. But we know that good functioning CRVS is critical because if we can detect those deaths, then we can do exactly what the Minister of Health in Turkey did. Every time his system picked up a death of a woman, he did a personal maternal mortality audit. And the entire system changed its behavior because he would personally ask for an inquiry and say, what did the system do wrong? Where did we let down that mother? And so I think that's what we're saying. We're saying invest in those accountability systems, not so that we have them for beautiful reports here in New York, but we have them for the policymakers who are going to act on that information in real time. Lastly, alignment. There has been very impressive alignment in many areas through something called the International Health Partnership Plus, which really puts countries at the vanguard and says the role of the international community is to align around those country plans and to support them fundamentally. In addition, in this community, the H4 Plus has been exemplary in bringing the community together with respect to consensus on the type of investments, identification of where those bottlenecks are, and how we as a community can overcome those bottlenecks. So all of those principles are going into defining what the GFF is. We've had a working group over the last couple of months. It's developed a concept note. We will have an event later this week in which initial commitments will be made, and in many respects, and in an analytic way, we're breaking ground. And we're breaking ground because we know that the financing component to this dimension, to this agenda, needs to come into greater resolution, and then over the next 6 to 9 months, we hope to give the definition to the GFF such that it's fully operational by this time next year. Thank you very much.
Thanks, Tim. I didn't time you, but I think that was pretty good. So on my notes, it says to call on Ambassador Marijke Winrots, but Marijke. The Global Fund, through its health systems financing, through HIV, TB, and malaria financing, has actually gone a long way to saving lives, as we know. But in recent years, we hear more about how it's also working on a more integrated approach. So how do we work through this complex financing landscape to produce the best results for women and children? What does effective complementarity between financial institutions look like? Thank you.
All in 3 minutes. And just to set the record straight, I used to be an ambassador for HIV and sexual and reproductive health and rights of the Netherlands before I moved to the Global Fund. So when I saw the mistake of the ambassador before my name, I was just wondering whether moving to the Global Fund was a promotion or a demotion. I'm not sure. Anyway, really pleased to be here and part of this really interesting meeting. So I'll try to be really brief in highlighting some of our recent experiences. The Global Fund, as you can see from all the reports, is and always has been a major funder of PMNCH. And only by investing in AIDS, TB, and malaria programs, the Global Fund has made a significant contribution to the health of women and children. Our strategy 2012-2016 actually includes one strategic action to increase the impact of Global Fund investment on the health of women and children. And looking back, I think we have been too reactive. Countries like Rwanda, the always eternal example of Rwanda, setting the good examples, that had strong policies, national policies and integration. The Global Fund has supported integrated programs. Countries that didn't have strong policies, the Global Fund didn't really explore options to work in a more integrated way or to encourage better service integration. So actually the last iERG report 2013, the submission of the Global Fund was not even included because it was not relevant. So we've come a long way. We've adopted a new model of working, supporting countries, the new funding model. We still call it new funding model. We launched it in March 2014 and we're really full swing, a country of full swing, developing concept notes. And so that allows us, because it's a different level of engagement with countries where we support countries' national strategic plans and encourage a wider dialogue at country level involving the broader group of stakeholders in health and not just AIDS, TB, malaria community. So it provides us with much greater opportunities to support service integration. And actually when I was listening to Diane's presentation and one of the recommendations from the PMNCH 2014 report on sustainable accountability to better coordinate our investments to increase efficiencies and effectiveness and thereby having greater impact on women and children's health. That's very much what we're trying to do now. So how do we do that? We have, so that the dialogue at country level is much broader. It just, as I said, it includes stakeholders beyond the traditional HTB malaria community. We encourage civil society, key population networks, but also the RMNCH community and women's organizations to be part of the dialogue and make sure that their priorities are well reflected. We have a technical partnership agreement with WHO, which includes technical support to countries to support integration of RMNCH and focus on health system strengthening. We have recently signed a number of MOUs with key technical partners. UNICEF, beginning of this year, and Nikki sitting here was a key advocate for that collaboration. UNFPA more recently, and also have much closer engagement and collaboration with the World Bank, specifically with the RBF, the Health Results Innovation Trust Fund. So we have an opportunity to support service integration. We had set our own ambition and corporate operational key performance indicator that of the 15 countries that we prioritized for 2014 in our collaboration with UNICEF, we would wanted to have by the end of 2014 that 8 out of these 15 countries would have submitted a concept note that did include integrated service services. I was really pleased to see that after 2 rounds of the technical review panel, so submission of concept notes, we're already at 7 out of 15. So I'm very confident it will well exceed the target that we set ourselves. And we thought it was quite ambitious at the time, but there's clearly a strong appetite at country level to work in a much more, to have partners work in a much more integrated way to support them. It's also interesting to see some of the spin-off. So apart from the fact that we have had now quite a lot of joint training sessions involving people from country level and consultants that support countries to think much more about integration. One of the interesting spin-offs is the joint work now that is really re-energized about supply chain management. I remember when Mickey and I started chatting about service integration around child health in DRC, that we soon realized that the supply chain systems for the malaria components and the non-malaria components of IMCI were very separate. And that didn't make a lot of sense. So actually just seeing real-time the sort of issue that countries struggle with, all the separate fragmented supply chain management that different programs have introduced and supported, really brought us together and has given a lot of boost and energy to a much more coordinated effort to support countries to have integrated supply chain management systems. So I think we've come a long way since last year. We are very committed to do even more and look forward to the discussion. Thank you.
Thank you, Marijke. And now we call on Honourable Minister Dr. Agnes Binawayo, Minister of Health, Rwanda, because we've talked a lot this morning about, and I just heard it in Marijke's, what countries cope with or struggle with. I mean, Rwanda, as we know, is very much up there with being very explicit about what this all means at country level. So could you tell us, Honourable Minister, from your experience, what can states really do and funding institutions together to put in place a system that really makes effective use of resources? So when this money is coming out to your country, how can we work together a lot better than we've done so far?
Thank you. We struggle. You believe Rwanda is there. Rwanda is struggle day and night, isn't it? There is no day we are not struggling. But what we can say to answer your question is we need to invest in system. And we need to invest in system in a holistic manner, meaning don't take the woman when she's pregnant. Think about her when she's a baby child. This baby child that needs vaccination, she will become an adolescent that needs to be informed in reproductive health, and she will be a pregnant woman that needs to have access in a walking distance, because in our country they don't have a car, they don't go to bike. Many have in some countries like Benin, they have a motorbike. But so they need to have service where they are living. And we need to frame, and you need to finance that. So one question, don't come and think here, because I here understand that you think about my birth registration system. Ask me what I need. And we have a good plan through community health workers and phone, etc. And don't go and think it's broader. We know what we need. Just come and ask us. So this is how to create a system in an holistic manner during the lifetime and with equity. You need to find out if the country is served in the same way. If the country is served in the same way, just go sleep, your money is safe, at the condition that you pay for the right thing. So we need to know, country by country, what are the bottlenecks, where the women are dying, where the children is, when the child are not vaccinated, etc. And also, I hear somebody talking about the most vulnerable. I used to say that if I'm working for the most vulnerable family of my country, my grandchild is safe. So target the most vulnerable and don't think about what it will bring to the rich people. And then, what is the problem? The most vulnerable people have to be tackled. But this means also you need to create it in the framework of development. And this is, that's true, a country matter. Global Fund has done a lot for women and children. Yes, but not proactively. It's a consequences of the good work for HIV, TB, and malaria. It should have been proactive because many countries doesn't know how to do it. They know what they need, but they don't know how to do it. So funding vertical things, what is the outcome of that after? If you embed the support you give for HIV, for vaccination, etc., in the system, and where the people are living, you'll get the right result immediately. So the world have learned a lot, but unfortunately, we suffer from amnesia, chronic amnesia. Today it's Ebola, and everybody is screaming, Ebola, Ebola, Ebola. Madam, sister, I'm sure when it will be solved, they will forget Ebola. And that's the problem. There will be something else. 20 years ago, it was HIV, HIV. We had the chance that the civil society in the North has struggled a lot for those rights. Fortunately, Ebola doesn't tackle this country. So, madam, my sister, that's true. Africa should come together more strong. But the people who are giving the money should think ahead. What are you building for the future? You should think 2035, isn't it, Dean Jamieson? We have worked on investing in health and provide the world with a very good recipe how to reach the MDGs and the post-MDGs. And unfortunately, look how you are fragmented. The UN have their post-MDGs. The AU have their post-MDG. AU, EU, and etc. It's not the triple S and double A, but it's something, and everybody has the same objective. You spend millions in meetings. What is coming out of that? Could you come together like big boys and big girls and work around an agenda? And you make my life miserable. Because I should not be here, I should be in Addis. But because I want to be here to say, to give that message, I'm not in Addis. Because the world is fragmented. You ask us to be organized around the building of system. You are not organized around global health, guys. And you make our life miserable. I spend my life to be jet-lagged because of you. And also, it's good to have good report and good data. I love data. Isn't it WHO and UNICEF? I love data and accurate data. But my people spend 50% of their time to report to you. And me, I want them to give 100% of their time to save life. And this is also unfair. So we need to think about simple way to report, trust, and simple control. You make our life miserable. You know, I got 3 Global Fund audits this year. Gavi audit now. CDC audit in 2 months. When are we working and saving life? So all those fragmented and chaotic way to do business, we should stop it. So we should learn about that. And in one word, I can just say, we need to build a system nationally. It's our responsibility, but we are disrupted by you. And you need to come together, even without us. Go in a room. They do that in Vatican. They just go all out when they have a consensus. We should put Ban Ki-moon, Margaret Chang, and all the others in a room, and they go out when they have a consensus. Yes. Huh? This should be the outcome of here. So, but don't forget participatory process, using the people, ask the people what they want, and build for sustainability by focus on fighting poverty and disease. We need to be flexible, and that's true that there is more money, but the money has less value, that in the end we receive less. So, and just ask to Dean Jamieson his report on investing in health. You'll get the recipe for the post-2015. Thank you very much.
Thank you very much.
I will take the key of the room.
Yes, I think the room in this context, it's not the Sistine Chapel, it's called the UN General Assembly. So maybe you take the key, lock them all up until the white smoke comes out. Okay, so we'll move on to Mrs. Anuradha Gupta, who's the Deputy CEO of Gavi, the Vaccine Alliance, and until very recently, the co-chair of PMNCH. So, Anuradha, raising resources in a tight fiscal climate is something that all agencies face. Making vaccines available to the hardest to reach, I think it's the fifth child is the phrase that's used, remains a challenge. So how does Gavi envisage scaling up its impact to these vulnerable populations in the current financial climate? And how can page 7 is down here, sorry. How can a global, excuse me, sorry, it's very early and I'm also jet lagged. How can a global financing facility support Gavi's ambitions to accelerate equitable access to vaccines? Sorry, I hope people got the question despite my mangled delivery.
Thank you, Carol. Taking the floor after such a strong, powerful, candid voice from the country, grounded in experience, is a very difficult challenge. But I would just say that, we are all aware, Gavi has successfully immunized close to 500 million children with additional immunization. And we are really setting our sights much higher now. In the next strategic phase, 2016, 2020, we are now aiming to reach another 300 million children with additional vaccines and also reaching 3 million adolescent girls with HPV vaccine. And this is going to cost us more than $11 billion 2015 onwards till 2020. But we must be aware that 75% of this is really the cost of vaccines. And if we want to reach the fifth child, and there are 20 million such children in low-income countries who are still deprived of the basic DPT-3 dose, and if we really want to tremendously increase the coverage of all the 11 antigens recommended by WHO for an infant, coverage stands at less than 10% today, then we really need to invest substantially in health systems strengthening. And that is what we have been hearing. I'm glad that is what has been echoed again and again this morning also. I also feel that the total investments in health systems that we have witnessed so far actually are quite short of the requirement. At best, they are a drop in the ocean, even when we do not take into account the several fragmentation challenges that have been mentioned, included by the minister from Rwanda. So in Gavi, what we really want to do in this new strategic phase to reach that last child is really something very different. A lot of people have been talking of positive deviance. Why is it that certain things happen better in certain areas and geographies? But I think really the challenge now is to learn from positive deviance, but actually stand up to address the negative deviance. And I have always personally believed that we talk of inequities, we talk of deep disparities, but we haven't even started to really map and identify those invisible faces of women and children who are completely unserved or are really underserved. So I think trying to really look at those subnational inequities and tracking those geographies and populations where our services are not reaching. And I know immunization normally is the first service to reach at the primary health care in communities and outreach settings. That is going to be a priority with us. Coupled with this is the fact, something that was highlighted by other speakers, but also the minister from Rwanda so powerfully. In Gavi, we now believe that we cannot have top-down global plans. We really need to encourage bottom-up planning. We really need to repose faith in the capacity of the countries to present to you highly integrated, very sound and robust plans which are based on bottleneck analyses. And this is really the time that all of us must unite, must harmonize all the technical assistance, the technical support, the grants that are flowing at the country level to make sure we support these country plans. Now here, and Peter presented that, we have seen 55% of ODA now through bilateral mechanisms. So clearly, there is a big part of the money which is really going directly at the country level to the countries. And therefore, I think moving forward, one of the challenges is going to be how do we all unite? How do we put our hands together? How do we hold each other's hand and actually truly and sincerely get committed to implementing the country plans? One thing that the minister said, and I've truly believed, having worked in country settings, that we have a lot of expectation from the countries, but we have very little appreciation of the fact that countries have weak management capacities. And I think it is overwhelming for them, the kind of requirements that each funding stream brings. So I think really the starting point is to invest in building the management, coordination capacities at the country level and encouraging country level leadership. And that is what we are really wanting to work on moving forward to address our challenge of increased coverage with equity. Now coming to the issue of GFF, I think Tim very eloquently elaborated the concept of GFF, the thought behind this. I think it is a tremendous initiative. The biggest, and one thing that I really want to repeat here, Tim, is that it is no longer RMNCH GFF, it is RMNCH GFF. For the first time, we see adolescents included in this concept, and that's a hugely, hugely progressive step for which I really truly wish to compliment the entire GFF working group. We also find in this GFF a very explicit articulation of really looking much more broadly at the health of women and children, and really moving beyond survival to ensuring their overall health and quality of life. Now, having said that, for us, GFF is important because we think that this facility under the aegis of the World Bank can truly leverage the influence of the World Bank vis-a-vis the ministries of finance to truly position RMNCAH as a developmental imperative and to actually start a movement where countries stand up and progressively commit to scaling up their domestic investments in RMNCAH. But having said that, I think it is critically important for us to think very hard about why similar initiatives at harmonization and convergence in the past have not worked, and actually learn from those to make sure we do not repeat those mistakes. In this context, one thing that I really want to say is that in health, convergence is a very attractive word. It is also a very desirable direction to take, but it has its limitations, let us not forget. So I think the litmus test is going to be to very carefully identify those areas which lend themselves very successfully to convergence, but also at the same time continue to be mindful of the very specific requirements of certain dedicated interventions. And I think that is the trade-off which, if GFF is able to strike, we think it would hold huge potential and promise. And therefore, complementarity to the highly successful initiatives today, such as Gavi, such as Global Fund, is going to be extremely important. The last point that I want to really make is, it is a highly strategic direction on the mix of financing that GFF is taking. But let us not forget that financing divorced of programmatic sensitivities can actually be quite problematic. So it would be important that you have institutional arrangements for GFF and governance mechanisms for GFF which bring together key actors who really work in RMNCAH space and make sure that the needs of the programs are actually respected, and with this smart strategic mix of financing, we are able to make progress, but most importantly, we are able to reach that last child and that last woman who is not on our radar today. Thank you.
Thank you very much to all our panelists. We will have an opportunity after Richard has presented the iERG report to have discussions. So please hold your questions to these panelists for the discussion after that. But I would like each of them to reflect maybe for 30 seconds to a minute or two in what you might call a tweet rather than a blog. If you could react to what you heard from your co-panelists. Maybe start with Tim, who's busy chatting, so maybe we'll start with Rebecca. Sorry. It's all right. I was just asking you to wrap up and reflect on what you heard from your co-panelists, and that'll help then guide the discussion afterwards. I said in a tweet rather than a blog. So we'll start with you, Tim, because that was the order in which we did it.
Sorry, Carol, I was hearing the intricacies of registration in Rwanda, which were really very fascinating. And so you want me to wrap up here?
Just if you want to just not wrap up, I'm not going to summarize, but if anything your co-panelists said triggered any thoughts you wanted to share in 30 seconds or less, please go
many
for it.
things, and thanks. I thought it was an excellent set of comments. But first, I really think the principle of putting the most vulnerable first as the litmus test of performance is absolutely critical, because we know, thanks to people like Tudor Hart and others, that those with better means will find ways. It's not clear that those with the least means can navigate systems on their own. So if that is the principle around which we organize ourselves, I think that's extremely important. And I think Anya's made that abundantly clear. Second is the value of really supporting countries to come up with stronger institutions and capabilities to lead and manage the massive interest that's out there, which can be overwhelming and fragmenting. And so I think those plans, those institutions that are critical for for moving those plans forward, and in the area of finance, ensuring that all external assistance is on budget. And unfortunately, that's not the case in many places today. And we do have evidence of serious substitution, which is not the direction that we want to go. We want to move additional. And I think that that's inherent in this movement towards greater alignment around country plans. The issue of bilateral mechanisms and recognizing that bilateral financing in the ODA community remains and is likely to remain one of the primary forms of financing. How do we make sure that bilateral financing is contributing to the whole? And that, I think, is a particularly important group of financiers in specific contexts, because they work according to priorities of their governments in terms of the countries that they're in or not. But making sure they're joined up and part of the plan is extremely important. And the last thing I want to say is that I do think, as Anuradha said very articulately, that we need, as we move up, to understand and recognize the value added of specific financing mechanisms. For example, I think she was referring subtly to Gavi, but where there is a proven track record, particularly in the market shaping on pooled procurement to get best prices and financing of vaccines. That is a huge asset that is managed together with UNICEF. And that is something that should be sustained, nurtured, promoted moving forward, especially when we look at the agenda of a greater menu of vaccines, many of which are still expensive and unreachable, and therefore not affordable without some very important market shaping. So I think those would be some of the takeaways that I heard, which I thought were very, very helpful.
Marika, one sound bite, because Richard Horton is sitting behind you, and that's not good for your health, any of you. And then we'll go to...
I'm very afraid of Richard Horton. So I had actually 3 take-home messages. I'll skip the first 2 and just go to the... And the last one, it's, I think, for me, is also very obvious listening to all the presentations this morning, the need for differentiation. We have countries like Rwanda that basically... I believe you, Agnes, that you're still struggling, but I think you struggle maybe at a different level.
No, I'm struggling hard.
I
disagree. It is not simple.
But no.
Maybe Marika finishes her second point, and then I go to Anuradha and Agnes. You definitely get the last word.
Yeah, no, definitely. No, but the need for differentiation. I think if you look at and I will not talk about. I will take the discussion with Agnes offline. But if you look with the wide discrepancy, I think in Peter's slides between the mortality, maternal mortality, and the investments in health in country and the country with the highest mortality actually have the least funding. There's also really fragile states. I don't think, as a global health community, we've got our acts together on how we support fragile states to really build their health systems to the level that they can provide the services their populations deserve and need. And I think it would be another topic where the global health community should be locked up.
Anuradha?
Carol, very quick 2 points. One is data. Minister of Rwanda sort of touched on this, the intimidating requirements of data. I think it's important for us to understand that there is a need for us to be less demanding in terms of indicators that we are looking at. In all, there are more than 600 indicators, right, in health space on which data is required. I know there is separately an effort ongoing to reduce that. So I think it's going to be really difficult. How do you reduce that? But yet, how do you make sure that you really get critical data on dashboard indicators? The second really is accountability. We have been talking a lot of accountability for results. I think it is about accountability for outcomes at country level, but I think we are all a part of this accountability. Each one of us has to really hold ourselves to account, for what we are mandated to do and the extent to which we have really delivered on that promise. Thank you.
And Honourable Minister, what would make you most happy?
What would make me happy, first of all, is that if out of this meeting you decide to coordinate, I think I will found that it's a miracle. More than 10 years, the world has that, HIP plus, whatever plus. Huh? We have say, and we still say, and you don't do. So I would like you to be accountable, at least on that target, but really accountable. So also what I want you to know, it is not easy, and you mislead my colleagues when you believe that for Rwanda it's easy. My sisters, it's hard, hard, and hard for day one up to today, and I think the next 10, 15 years it will be hard, because it's a constant effort to put every single action in the framework of development, in the framework of participatory process and equity. So it is an exercise where we need to bring the entire nation, and it's not easy. But it's, in any case, if you don't do that, you will fail. So it's a pleasure to do that, but it's not easy. For all what my colleagues have said, I agree, but I want to attract your attention on another issue we didn't talk about. Pool procurement, okay, but international ethics. I would like us to fight to put fake drugs as a crime against humanity. You know why? It kills more than war. Last year, we discovered that we have invested 18 million provided by the Global Fund in fake bed nets. And we had everything right, and malaria increased. So we believe the people were not following. So we create a break in confidence. Our people doesn't trust bed net anymore. So we had to start afresh. Those people who have done that, they have nothing. They just eat our 18 million and the millions of others, because they have also received millions from PMI and all the others. And they are free. And they have killed how many people? So I want the international community to stand up against this crime. And also the international community to wake up more early, because WHO knew it 6 months before the rise of malaria in my country. We discovered it our own. It's not proper. So pool procurement, okay, but ethical governance for this, it's a crime against humanity.
Please thank our panel, and I think that's a very good segue, Joy.
Thank you very much to our distinguished panel. Thank you very much. And I would like to invite the co-chair of the Independent Expert Review Group, Richard Horton, to come and deliver the key messages from our report. You have 10 minutes, Richard.
Thank you very much, Joy. Are you ready? Let's go. I am not me today. I am a composite of Joy Pamafi, Carmen Barroso, Zolfi Buta, Kathleen Ferrier, Serge Al-Hathi, Dean Jameson, Tarek Magwid, and Miriam Wuri, and only a little bit of me. We are the usual suspects, and apologies, and please accept our forgiveness. We strongly endorse the White Ribbon Alliance's call for more country voices, and I came in here today with Larry Leeser, celebrated Kenyan poet, You should be hearing from him, not from me. What a year it has been. Here they are, Prime Minister Harper and Ban Ki-moon, signing the check for $3 billion. Incredible. You've seen this curve before, MDG 4, yes, accelerated progress, but a shortfall. So not success. Not success, as it said in the UN General Assembly 1 year ago. Indeed, great deal of uncertainty. This is what the UN and the Institute of Health Metrics and Evaluation agree on in terms of countries that are going to meet their MDG 4 targets by 2015. You can see there 7 countries. The UN estimates that these countries will also meet their MDG 4 targets. IHME disagrees. IHME proposes 2 other countries that are going to hit their targets. UN disagrees. We have confusion, we have uncertainty. Does it matter? Some say it does, some say it doesn't. We have uncertainty and confusion about that too. MDG, and let me just say one further quote from Jennifer Bryce, very important quote from the Countdown Group, that if we're going to make progress, we need ruthless prioritization of quality delivery for a small number of key interventions. MDG 5A. We start off in very different positions. You can see back there in 1990 for IHME and the UN, but incredible convergence to where we are now. Progress, but a shortfall. Look at MDG 5B, increasing unmet need. That's the dark line, the black line with that green area of uncertainty. We want to bend the curve where the red line is going. Can we? Can we? We don't know yet. We don't know yet. We don't know yet. Let's acknowledge our uncertainty here. We want to believe we can. We have Family Planning 2020, but are we going to deliver? We have to work harder if we are. The key evidence that we found was unprecedented, unbelievable political mobilization. Yes. What else do we see? I have no idea. Here it comes. Positive impact of donor financing. As you saw from the PMNCH report, disbursements are aligned with need. Very good, but additional investments are insufficient. Face up to the fact that we are still not investing enough in women's and children's health, and critical gaps remain. We know what those are. Here they are: newborn, stillbirth, sexual reproductive health and rights. Family planning. Can we please talk more about family planning? Nutrition, high-quality health workers, women and children in zones of conflict, sexual violence. Nobody's mentioned abortion yet. Unsafe abortion is a huge and unaddressed threat to women's health, child marriage and FGM. Let's move on. Let's move on to COIR. These are the advances from 2013 to 2014 in the goals and targets of the Commission on Information and Accountability. The important point to mention here is that we are seeing advances. 6 out of 10 of the indicators are making progress. Are you keeping up? We're on page 34 of the report. Here is the money. We owe a huge thank you to all those who have invested in the Commission on Information and Accountability. Canada, the UK, Norway, Germany. But you will see from this slide that there is huge variability in those investments over the years. Sometimes a year was fabulous, and then we're in a period of fallowness. We need to have greater consistency in our investments. Let's look at progress we've made on our past recommendations. In 2012, we wanted to strengthen global governance. There's a lot of argument about the work of the RMNCH Steering Committee. It meets this afternoon. Is it doing its job or isn't it? Let's discuss. A revised global investment framework. We've had the Commission on Investing in Health, and Flavia Bustreo in particular at WHO led a very successful effort in defining that investment framework. We need to set clearer country-specific strategies, and we took part in 2 visits to Peru and Malawi this year, and I will tell you a little bit about those in a moment. Accelerating e-health and m-health. That was the big fashion a couple of years ago, but there's a huge gap in reliable evidence about whether we're really making progress on e-health and m-health. Strengthening human rights tools, we've done well here. There is a comprehensive platform to build on. And evaluation, the research community is fantastic, but totally uncoordinated. On 2013 recommendations, strengthen country accountability, we said, and we have seen substantial improvements. Demand global accountability. Work is progressing, but there are many uncertainties about that work. I will touch on that later. Take adolescents seriously. Again, substantial activity, particular leadership from WHO. Thank you. Prioritize quality. That has become a high priority, and Marlene Towerman has done particularly important work on that. Make health professionals count. A lot of words, not so much action, and very little evidence about progress. And a new movement for better data, yes, accelerating political commitments, and we should pay tribute to the Independent Expert Advisory Group on the Data Revolution for Sustainable Development, and my colleague Carmen Barroso sits on that. iERG members made 2 visits this year to countries to study accountability, one to Peru and one to Malawi. What did they find? They found progress. They found progress particularly thanks to the engagement of civil society, but they also found lack of awareness of the global strategy, lack of awareness absolutely of COIA, weak accountability mechanisms, sometimes gaps in transparency, health systems under incredible pressure. We plan to continue these country visits and country studies into next year's final report. What about the UN Commission on Life-Saving Commodities, which was added to our mandate 12 months ago? Well, you've seen this slide already. The only point to mention is, fabulous though some of the results show for coverage across the continuum of care, there is massive variability across that continuum. We're on page 52, if you're following. The self-report from the UN Commission, because unfortunately, although we were delighted to have the Commission as part of our mandate, it came with no money, and so an unfunded mandate makes it difficult for us to conduct our work. But the self-report from the Commission on its 10 objectives told us this, that there are 32 targets, and they report that 19 of those targets have been delivered, that 10 have been partly completed, and the few 3 have not yet commenced. They also identified a series of challenges. The strategy and coordination team of the Commission, translation of knowledge into action in countries, alignment around the knowledge that we have and delivery in those countries, the right incentives to make things happen. Supply chain bottlenecks and gaps prevent effective delivery, and health workers are not fully prepared for the latest treatment protocols. When we looked at the evidence provided by the UN Commission, we also saw gaps ourselves. We saw gaps in financing, gaps in product innovation, gaps in implementation, and gaps in accountability. And truth to tell, with only 1 year to go, it's a very narrow time window for the UN Commission on Life-Saving Commodities to reach its intended objectives. What about post-2015? Here are the Sustainable Development Goals from the Open Working Group. Goal 3, of course, around health. It's going to be an even more complex picture post-2015. And so we wanted to try and design something that takes us beyond and complements the continuum of care. And this is what we've devised, the cycle of well-being, which tries to take account not just of health sector interventions on the left-hand side of the picture, but also non-health sector interventions, which contribute so much, perhaps as much as 50% of health across the life cycle, not just the continuum of care, but the life cycle for women and children. But we really need to understand the meaning of sustainability, and truthfully, the world has not done that yet. Sustainability means re-evaluating the determinants of women's and children's health, social, economic, and environmental. It means recognizing the interdependence of all peoples. It means intergenerational equity. It means thinking and acting beyond the health sector, and it means sustainability being about the value we put on the lives of women and children, not simply their price. Let's turn to 4 observations from all the evidence we saw. First, and I've already mentioned this, despite gaps, the pace of progress on delivering commitments is increasing. That is very important to acknowledge and celebrate. The landscape for women's and children's health, though, is about to undergo a seismic shift as we go into the SDG era, and we don't think people have understood how big a seismic shift that truly is. There are opportunities and uncertainties, and those opportunities and those uncertainties must not induce complacency or paralysis. And finally, accountability is a potentially powerful means to keep our focus on the prize before us. So here, quickly, our 6 recommendations. The goal, when you consider these recommendations, is this, and it's an incredible goal that we can achieve: to end preventable mortality among women and children within a generation. Our generation is the first generation in the history of this planet, the history of the universe, to be able to deliver this goal. So let's do it. Recommendation 1. We need a new global strategy. Develop, secure wide political support for, and begin to implement a global plan to end all preventable reproductive newborn, child and adolescent mortality from 2016 to 2030. That is a more inclusive, more ambitious global strategy for women's and children's health. Second, create that results-based financing facility. We were just a few weeks ahead of the World Bank and others on this, to support and sustain this new global strategy. We have the global finance facility that's been proposed. Is it the right facility? We need to discuss it. Has there been sufficient consultation? Has there been sufficient discussion amongst key partners? We need to start that consultation and we need to start that discussion now to understand what the financing facility really will deliver for women and children. Third recommendation, between now and 2016, if we really want to keep women's and children's health on the political priority of heads of state, a special session we call for at the General Assembly, led by the Secretary General, to accelerate international collective action for women's and children's health. Dean Jameson's Commission on Investment in Health was very specific about what international collective action means. It means aligning and harmonizing the actions of partners, promoting leadership, providing global public goods, managing externalities, and direct country assistance. But direct country assistance is only one small part of what we mean by international collective action. Recommendation 4, if we really want to deliver on health and human rights for women and children, establish a global commission on health and human rights for women and children to propose ways to protect, augment, and sustain their health and well-being. Over the past 3 years, we've developed an incredible platform for a human rights-based approach to women's and children's health. Let's accelerate the progress using that platform we have created. This is a picture that Tarek McGuid took for us on his, from his clinics and his observations. Fantastic commitments around rights. Are we really delivering them? Truth to tell, no, we are not. Fifth recommendation, if we really want to promote civil society-led accountability, let's do it. Let's create a civil society-led World Health Forum adjacent to the World Health Assembly to strengthen political accountability. Many ideas have been proposed over the years to do this. Here's one. It can be done. Let's do it next year. Sixth recommendation and last recommendation. In 2015, establish and fully resource. Fire us. Fire the existing iERG, but for heaven's sake, please, establish an independent mechanism for accountability to monitor, review, and propose actions to accelerate progress towards improved women's and children's health. We do not buy the idea of open source accountability. We do buy the idea of a UN mandated mechanism to strengthen accountability for women's and children's health. As Prime Minister Harper himself said, and this is a quote from earlier this year, we must ensure that global spending on women and children is targeted, effective, and accountable. That's it. Let's not miss these opportunities we share. Thank you. Thanks to the iERG Secretariat. Thanks to all who've provided evidence. Thanks to partners. And thanks to you for what you're about to do.
Thank you, Richard. I'm sure you'll all agree that amongst all his other qualities, he is our megaphone. Thank you so much. And I'm underscoring the mega here because the job that needs to be done is massive. And we are right now at a huge crossroads. Where are we going to turn? Are we going to continue and build on the successes and the strong foundation we have set to actually reach the stage that every woman and child is entitled to when they do not die or become handicapped, suffer morbidity from preventable causes? Or are we not going to do that? And I would like to invite here a very, very important leader in making this decision and determining the way forward. The UN Special Advisor on the Post-2015 Development Framework, Ms. Amina Mohammed, to share with us where we are going from here. This mega, mega, mega responsibility that we have. How are we going to get there, Amina?
Thank you very much, and morning, everyone. Well, I'm going to say how we hope to get there. Whether we will or not has a number of roadblocks and potholes between now and September. But after Agnes spoke to us a little earlier, I have to say that for the last 10 years, I've been listening to what she said, and I was looking to see how much has changed. And that, for me, is a challenge of whether we're going to get to where we want to get to. If we can actually change what she said from those years ago to today and really make a difference, that will be a helpful transformation. We've heard today, really, that the MDGs are unfinished business, and I think that's the starting block for the post-2015 development agenda. We've said it from 2 years ago when we came out of Rio, and we continue to reinforce it. We continue to say we've got less than 500 days, now 400 and something days left to finish it, but it will be unfinished come September 2015, and I think the real focus is going to have to be on how we make that transition, that it really does become the baseline and then the ambition for what we need to do, given that we're in a very different place in 2014 than we were in 2000. So much more has happened to make our lives more complex and the challenges even greater in this interdependent world. The post-2015 debate has reached after a year and a half of a lot of negotiations and everyone's input, and I think for this community to get to where we've got to and seeing the recommendation that shows what you need to do on health, but what the other determinants are within the 17 goals, you can see the inputs that you've put in here have really shaped where we're going. The 17 goals and 169 targets, as I was listening to the efforts that you're going to be making in reducing 600 targets to 300, I thought, wow, and we're trying to get less than 100 targets for 100 indicators for the post-2015 development agenda. Again, it alludes to how much more complicated are we going to make the lives of people we're trying to help. And I think that this is something that we really need to discuss, and in doing that, how much of it do we give to the countries to develop themselves? I can tell you from my experience as a development practitioner, when we got the MDGs, the goals were there, and they were, for some ambitious, for some of us, they were the baseline. But what was really complicated was to try and understand how we made sense of the targets and the indicators. We dropped 3/4 of them. We didn't pay any attention to them until we came to the annual General Assembly. Then we got a consultant to come and do a report for us. That's the reality. So can we do better than that when we come to the next set of goals, targets, and indicators, that they will make some sense? And this really is speaking to, we've agreed so far that member states will lead and own this process. That's in New York. Will they make the connection with the capitals and with communities like this to ensure that implementation is going to make sense? Can we craft from what we have now, which are the key elements of a good and ambitious agenda, deliver on the ground? And I think that's another challenge over the next year with the goals and targets that we have and the work that we need to do on indicators. The means of implementation, we just have a frame for that right now. It's a skeleton. It needs fleshing out. We need to hear, as we hear about the GFF and the consultations that still need to be had, and the sense we need to make of what really is financing that influences the real investments that get us results on the ground, and how do we bring all of this together behind one, that we're not double counting or double dipping or duplicating. We need to answer those questions going forward if this is to be business unusual, and that those usual suspects are to do something transformational and allow others to carry this forward to the ambitions that we need. So the means of implementation is going to go beyond our 0.7. Clearly, ODA is extremely important, especially for our low-income countries. But it's insufficient for what we're asking for. It won't do the job of resourcing the menu that we're putting forward. And that means that we need to unlock resources. And it's not the resources are not there. I think time and time again we've heard where these resources are, but do we have the political will to unlock them? Do we have the political will to stop them leaking out of the pipelines that we see them doing so? Even as I hear us speak to illicit resources and having a register of where it all is, it's one thing to know where the illicit resources have been taken to. It's another thing to get the instrument to get them back in our countries. It's also another thing to make sure that those leaky pipelines are actually blocked and plugged again so it doesn't leak all the way back out again and we spend the next 10 years looking for where the illicit resources have gone. So there are a lot of questions that we need to answer about how to make this real and how to make it sustainable. And the means of implementation will go a long way to that. One part of the means of implementation that we've had lots of really exciting discussion, and a lot of it has come because of the health community, and that's on technologies. And we can say again and again how that's really helped us save money, save lives, better target expenditure, look for the vulnerable people. Still not there yet, but at least it ignited really good discussion on the floor of the Open Working Group. But where decisions were taken as to what we do with the technologies discussion in the Member States' General Assembly, then it fell to the lowest common denominator. Then we didn't have anything except find ourselves stuck between intellectual property rights and a mechanism that we needed. It lost all that energy around what we can do and what we have done and what we need to do in scaling up on technology. So how do we keep that at the highest possible ambition to make this an agenda worth spending our time on? Because that's the other challenge, is that 15 years down the road, countries are doing what they need to do. They have visions, they have plans. They're not waiting for the United Nations to come and save their lives. They're saving their lives. They could do better with what we have because that's what we're supposed to be there for, to lift this agenda so that we can make people reach those ambitions a lot quicker than we have been doing in the past. The Secretary General has a huge ask from member states, which is to produce a synthesis report by the end of November, bringing all these strands together, stitching everything that we hear to make a coherent whole, to clarify what it would mean to deliver this agenda on the ground. And not a prescription, but really to give some idea as to how these goals and targets will respond to the backdrop that we have, the challenges that we have, not just developing countries and the investments needed in people and planet, but what about the countries that are in conflict, those that are coming out, that are struggling to try to make not just the infrastructure work or rebuild it again, but what about the people? What about families and societies and communities that are broken? And that's not a quick fix. That needs long-term financing that happens regularly, day in, day out, with the support, the human resource support. And you can't always buy that. You can't always buy that, and that needs to be put in place to build back our countries. The synthesis report, huge expectations from it, and I can say that the Secretary General will show the leadership that's needed to do the right thing. A lot of pressures as to what he should and should not say in the report. But I think he has to be that honest broker that does right by people, does right by the billion that are still living in extreme poverty, that does right by the potentials of the young people that we have and that we need to carry forth the agenda, does right by those who have been trying and being in the trenches for the last 20 years to get their head above water, and just as they do, another wave comes across. So we really have to lift this to scale. It no longer has to be about, and I can talk about my continent as a laboratory with countries being petri dishes, out of the petri dish to scale. We know what to do. We know how to do it. What you need to do is to listen to us as what we need to achieve those ambitions. And I think that this is where the challenges come when we produce a synthesis report, to show that leadership, to be ambitious and keep the momentum, and to ensure that it does make that bridge into the beginning of this 1 year of negotiations. Not much probably will happen in making more or less of the 17 elements that we have. We will be more specific on the targets. Those 169 targets, many of you will agree, are not targets. There are indicators there, there are political statements there. We have to get clarity from that. We must begin the work on indicators. It's not reinventing the wheel, but it is being responsive to a new agenda, which now looks to see a Minister of Finance not decide around a cabinet table whether health gets 7% or 15%, but they actually see the success of the growth in the economy, the impact that they have in the health sector with the investments that they need to make. This is a different way of thinking about how you invest in development than our countries normally take up. I can see that the president of the IPU here, parliamentarians are going to be a key part of this. And as you speak to accountability, their first job is oversight. And along the way, they have appropriation. So they will make the investments we need. If they're not involved, they're not going to do it. They're going to take a long time for them to understand why they should. At the end of the day, this is a political agenda. And so therefore, it is these politicians who are in for 4 years, max 8, maybe 10, that are going to be making the decisions. How do we make sure that those decisions that they make actually survive the next administration that comes in? And that we don't just see these as 4-year interventions and then we lose them and we rebuild again. So that it is a political agenda, I think we need to speak and communicate to those at the country level who need to carry this. Leave for civil society to also advocate for what needs to be done. In looking to the synthesis report, I think a lot of the unfinished business on what we need to flesh out and get commitments to will be the means of implementation. And from January, we have many opportunities. How business can come on board even more strongly than it has through the different initiatives that we've seen work through Every Woman, Every Child. But Davos provides us a really useful platform. Bringing development into that space is really quite difficult. Anyone who's been to Davos will understand that. But health has done a really good job of pushing that. So has food and nutrition. And then I think we need to push that so that success at Davos in 2015 is that the private sector, business, actually runs with this agenda because it sees a really good deal in it. But we want to deal not off the back of people, with people at the center, the planet at the center. That's what we'd like to see out of Davos. Moving very quickly into another opportunity where the bank and the IMF have provided a space to really think about the instruments that we're going to need for this. And in doing that, how will that then land in Addis, in Ethiopia in July, when we really talk to the commitments that we're going to make to financing for development? And the financing facility you talk about will be very much affected by the decisions that are taken there. It cannot be held in isolation. Those funds and those flows invariably come from the same places. So finally, I'd like to take up just a few points. You're discussing accountability here. And I think as I listened again to my sister Agnes, I think one of the points I made when I first came in, real intentions of going back to my country, Nigeria, at the end of next year, and hopefully with an agenda that they won't lock me up for, but one I can implement. And not say to me, Amina, you've come with more grammar. I haven't. But the first question I asked of the United Nations, are we fit for purpose? We're visiting a huge agenda on countries. It's different from what we are actually practicing on the ground when we say development now. And are we able to have the skill sets to be more coordinated, more coherent, to facilitate and not to dictate? To come out of those offices that we have and to really roll up our sleeves and help countries to achieve a massive agenda, to actually bring together different stakeholders, not just civil society or government, but business will be there, parliamentarians will be there. There'll be a different sort of person there. Even when we say civil society, there are many voices outside of that space who don't consider themselves civil society. They just want their voices to be heard without having to belong to one network or another. How do we make sure that we also capture those voices? So this is a huge remit, and we're pleased to say that the Secretary General has started this effort in already asking the UN to look at how it delivered as one, lessons learned, both for what worked and what didn't, and how can we do better responding to a sustainable development agenda. Often one is seen and hears that our agencies have taken a review, they've reformed, they're more efficient, more effective. What we're asking is that, are you for sustainable development? We haven't done it yet. So are we? And it's not too early to start on that. Really facilitating service delivery. When we speak about education and health, a lot of the service delivery is recurrent expenditure. A lot of what we speak about here is actually classified as capital, one-off. Maybe 2 years, maybe 3 years, one more minute, okay. But I think that we really need to think about the resources that we need on a day-to-day basis. Very quickly, data and statistics are going to prove to be a big part of this, but who's going to pay for it? It's not a priority on the many lists of government that we have today because it's a competing demand. It's often a choiceless choice. But the panel that we have and which Carmen will be serving on does the first piece of work of determining that outline of what we mean by a data revolution and how do we continue to build skill sets and institutions within countries, but also take advantage of data and not make them a competition, but collaborating. We will need, as we go forward, to align existing initiatives that we have with what is coming out of the post-2015. I see you talking about a strategy for every woman, every child. Can we make that alignment coherent with what's coming out of the Open Working Group and the post-2015 development agenda? And will it actually resonate with countries who are already embarking on, have embarked on their journeys? And so the country voice, I believe, is still the one that has to be heard. And so what we hope to happen in this next year as we continue to negotiate here is a deepening of that conversation and those elements that we say we have with countries, so that countries can come back when we come in 2015 and we begin the transition to this universal and transformative agenda. Can they hit the ground running? Because that's where it's going to matter, where we see rights, aspirations, resources all meet to make impact in the lives of our people. And let's start trying to work from 2030 back. So 15-year looking forward is a difficult track to look at, but looking back, where do we want to be in 2030 and how are we going to make that work with what we have so far? Thank you.
Thank you so much, Amina Mohammed, for that. You have really charted the way for us. And I think the important thing is that you are talking about putting people first, the countries first. And we have to remember that even as we speak about the biggest challenges being management of the health system at country level, perhaps an even bigger problem is management of the health infrastructure outside countries. And so as you speak about charting that way forward and actually taking the steps, this we have to keep at the back of our minds and be at the forefront of our actions as we move forward. Thank you so much for your guidance and for your leadership. We are going to have to really be very, very targeted and effective in managing the next 10 minutes before we close. So we are going to have 5 minutes for discussions, and I apologize for that. And then we will have a very brief closing of 5 minutes. Secretary General of the IPU, you have heard from Amina Mohammed that is going to be about political leadership. And it is about how you are going to ensure that a politician, during the 4 years that they're in office, is effective and actually delivers. So how are we going to ensure that there is stronger accountability for women and children's health, and that this accountability translates into action at country level? Please, I'll give you 2 minutes. Martin, he's behind you. Yeah, 2 minutes.
Thank you very much, Madam Co-Chair. Thank you, Amina, for making a very strong case for parliaments. It seemed to me that parliaments were the elephant in the room that were not being identified and dealing with. And I want to agree with you that it is going to be very important when we're talking about accountability, we're talking about sustainability. And this morning, I think Margaret Chan talked about equity. And it is Parliament that at national level is the embodiment of all of that sustainability, accountability, and equity. So whatever discourse we're having on promoting women's and children's health has to take this into consideration. And to answer your question very quickly, Amina and Joyce, I think that when you approach parliaments to solve the problem of accountability is to treat parliaments as an institution and not individual parliamentarians. As you've pointed out, there is high turnover among parliamentarians who try to build institutional memory in parliaments, which means that you look at not only the parliamentarians, but also the infrastructure that is in place, the parliamentary staff that are there who serve longer than the members of parliament. So you work with parliament as an institution. And secondly, I think that you look at the global level at those institutions that bring together mobilized parliamentarians and parliaments and see how you can forge partnerships. For instance, the one that we have with WHO, PMNCH, and the IPU to mobilize parliaments on a regular basis so that this is on the radar screen of parliaments day in, day out. And I think that if we could address this issue of sustainability from this angle, we will make substantial progress. Thank you.
Thank you so much. So it's about working together, it's about reciprocal campaigning between the institutions that define these democratic institutions. Thank you very much. Can we have just a few comments on the floor and make just one point, the one point that you would like to leave us with? And could I start with...
I'm Theodros Malesa from the International Planned Parenthood Federation. My just one humble request is to include in the accountability the issue of denial. What I mean denial is we know reproductive health is as a center of any life and it affects a woman's life. Abortion is killing so many women, maternal health, and that is a result and consequence of sexuality, uneducated, unprotected, the HIV and so on. But from what I've heard, there is a reluctance to recognize there is anything related to reproduction, there is anything related to sexuality. Unless that denial is cut, we are talking about fire brigades, but not preventive and going to the root of the issue. Thank you.
Thank you so much. I'm sorry, I cannot see, so if I just point, please introduce yourself before you speak.
Larry Lisa poses the question in a poetic manner. We have had it said, unprecedented progress. Consider the citizens of Liberia. Incredible advances. Consider what is being done in Peru. Remarkable opportunities. Consider the people of Rwanda. In 500 days, the citizens have spoken and things have been done. In 500 days, Uganda has made improvements and increasing nature in advances and funding in 500 days. But what shall we do in less than 500 days? Will we give more voices to the citizens? Can the usual suspects give more of their slots to the people and the citizens to speak, Richard? Thanking the usual suspects, female, who have given opportunities to the citizens. Less than 500 days, can we go for it and listen to the voices of the citizens?
Thank you. You did not introduce yourself, but I always say art goes to the heart of the matter.
My name is Larry Lisa. I'm a poet from Kenya, and I serve as a global champion for the White Ribbon Alliance for Safe Motherhood.
Thank you. Thank you. And as an artist, you have gone to the heart of the matter. Please, can we have...
Hi, I'm John Barrazzo from USAID. It's really hard to follow a poet, but so one, just this is always, there's a lot of food for thought. You've said focus on one thing. Thanks to PMNCH and the co-host for organizing this. It's always great. But I guess the one thing I would say is that there still seems to be this underlying tension between promoting and promoting systems investment towards, as Richard's quote of being ruthless, quoting somebody else, being ruthless in delivery of high-quality interventions. And that goes again to the tension, to some extent, we see sometimes between focusing on sustainability and focusing on what can we actually deliver and report on in the short term. So I just want to say that that's something that we've acknowledged inside of USAID. We prioritize systems investments, and we prioritize both the delivery of high-quality, high-impact, priority interventions. And we want to do a better job actually understanding how the systems investments can actually capture what we're trying to accomplish in terms of those priority interventions. So we will be contacting you and asking you to join us in that effort. It's going to build upon all the work that's been done in the past, MBB efforts and others. But we really think that this bridge has got to be a little bit better made before we can say, okay, we're all about systems, and we're all about trying to get these interventions delivered by the end of 2015 or shortly thereafter. Thanks.
Thank you very much, John. Ture, please.
Thank you very much. Very rich debate, very important in relation to what is going to happen for the next of the week, both in relation to the formation of the goals as well as accountability. I just mentioned that we in Norway, we have also have to be clear about where is it that the comparative advantage of aid compared to national resources lies. And this is going to increasingly be a case about smart aid. And we thought we had been smart because we have actually diffused, together with the World Bank, the type of innovations they have done in Rwanda to make those available in the rest of the world in order to improve on quality. And I think what Amina mentioned there also in relation to how can we now make sure that the technologies that are in the pipeline will actually have a maximal impact. And this all relates to making the smartest investments, as Tim referred to, and the comparative advantage of aid compared to national resources. Thank you.
Thank you very much, Ture. And I apologize that we can't take any more comments from the floor, but we do have a very, very important leader in mobilization of women and young girls at community level in our countries to come and give us the takeaway points from our important event this morning. And my sister and colleague and friend, Nyaradzai Gumbozwamba, is going to come and give these closing comments.
Thank you, Joy. When you look into your program, it says the road ahead. That's what the road ahead. The road ahead for the women in our communities is the road today. Because she has to have life today. She has to deliver tomorrow. She has to have life tomorrow. So the road ahead from the everyday life experiences that we have is not post-2015 very far away. It's now and again tomorrow. So therefore, as we look forward, it's very important that it's not just about the 500 days. It's about today, tomorrow, the 500 days, and the days to come. As we are in this room, we have the information, we've had all the data, we've had the analysis, but we know 39,000 girls are married off today. We are talking about 39,000 sexual encounters with adolescents without consent, a crime. We are talking about age-appropriate comprehensive sexuality education, contraception, family planning, health systems, accountability, justice system, education system, nutrition, fistula. We are talking about the totality of her life. Immunization, the totality. And therefore, this speaks to the issue of a coherent integrated intervention and less fragmentation, because it's that one girl whom we have to intervene with. As we move forward in this road ahead, it's about the 3 C's: context, conflict, climate. We cannot intervene, we cannot take the road ahead without listening to that girl in Yambio. She's in a conflict situation in South Sudan. Or that little girl that we saw at Seeds in Samoa, talking about climate and its impact. Neither can we forget the discussions in Belize or in Ukraine. Context and conflict and climate. And what does it mean for health? We cannot proceed as if the road ahead is a single highway, because it's not a single highway. It's multiple highways within which we need to secure human rights and the right to health. As we move on the road ahead, I was in the Commission on Information and Accountability and was on that table with President Kikwete and Prime Minister Harper, with Tore and others. I was feeling that deep pain inside, because we're still talking about women as commodities and consumers of health, and not as individuals with human rights, with self-agency. We need to shift the discourse and the framework so that we are lifting the engagement of women as people in communities who are finding solutions to their own issues. They are not just waiting for policies, they're actually finding solutions. So the road ahead is for us to embrace a stronger women's human rights or human rights perspective. And also a road ahead of recognizing that communities are contributing to their own well-being. There's a lot of community organizing, mobilizing, providing services. And that community intervention has to be part of the integration with our health systems, because they're the first call. The women come to the local YWCA to whisper, I have the 8th pregnancy. What should I do? Should I go to the clinic? Will they shout at me? Should I tell my husband? Therefore, the community is an extension of the health system. It's not separate from. And therefore, the road ahead is for us to recognize, to value, to resource, to partner, to engage with communities and lift the voices of citizens. That road ahead recognizes that we need to approach community philanthropy as part of the new discourse on resourcing, because communities are resourcing their own health and their own well-being. The data has been telling on this road ahead that is about leadership. What leadership? Bold leadership. Leadership that is courageous enough to go beyond the usual discussion, to discuss the uncomfortable discussions. That's the road ahead that I'm looking for. A road ahead where we can be comfortable with discussing difficult issues in order for us to come to solutions. Of course, one difficult issue for me is Africa. Africa is damn rich, filthy, filthy rich, from oil, diamonds, people, culture, tradition, rich, rich continent. And yet, we have the maternal mortality, infant mortality. And when we say mortality, we are even softening women dying, children dying. We call it mortality, and sounds very soft and nice. But we are talking about bearing, literally. A rich continent bearing. And then we talk about ODA as the solution. We have to shift that discussion. It has to be about how can the resources on the continent lift the economic capabilities of the continent for us to address the household poverty issues and for us to have a sustainable economies, that we can have that functioning healthcare system within which ODA can complement other than be the solution. That's part of the conversation, that the road ahead has to be part of the discussion in the means of implementation. Yes, direct domestic resources, the resources within the continent, but also ODA. And that has to be part of the serious conversation that needs to happen, because that's part of the means of implementation that we are looking at. The road ahead is about embracing technology. I work with 25 million women, and especially young women. You know what? We can no longer bury our, what do you call it, the ostrich story? Yeah? We shouldn't, because young people are talking about sex and sexuality and reproductive health. They are dating online. They are giving each other tips on where to get what after morning pill wear. We have to talk about reproductive health and adolescent health in a very bold way, because information is no longer just controlled by what my mother and grandmother and what the health system provides me or what the teacher in the class provides. The road ahead is understanding that the context is changing, and especially the context with young people. And how do we engage with technology, with media, in order to embrace a positive approach to delivering for health, both in terms of services, in terms of commodities, but also in terms of information. Lastly, the road ahead is about understanding that the world is globalized. I am an African woman who lives in Switzerland. At times, I feel we are missing the universality discussion somewhere. Because at times when we talk about every woman and every child, the discourse is more from the developing country's perspective. And yet, I also see my sisters struggling. They may have all the systems and everything, but we are also talking about the excluded within the developed countries. We also have the poor in developed countries. So we need also to take a very strong approach, which is a universality approach to it, but more so with migration. More so with migration. We have many women who come from developing countries for different purposes, for different reasons, and where some of these systems are not protecting the rights of women and girls to health, and it's a discussion we have not yet sufficiently. So I hope the independent expert review group, in looking at its work and moving ahead, is to really look at the universality, understand that there is globalization, understand there is migration and there is trafficking. And lastly, I've read so much of the post-2015, the open-ended working group, all these documents, and I go back to my village. I'm the last child in a very big family. It was hard. The greatest thing that we have to address is the issue of women and children's health is about dignity. It's not just about having health, it's about having dignity. The greatest indignity is to be able to queue for a cash transfer, to go for and get that little money, and then tomorrow you get that little money in order to send your kid to school. We have to address household poverty fundamentally. Yes, we need the conditional cash transfer. They're even conditional. But there's a lot of indignity in you being, to have a handout in order to give birth in a clinic. We actually need women to have jobs, to have employment, to have entrepreneurship, to wake up and decide which doctor they want to go to wake up and decide what they want to eat because they have all the nutritional chart. That's what we need. So I'm looking at the boldness. I'm looking at a bold post-2015 agenda as the road ahead, which links the issue of addressing household poverty with the fundamental right to health for women. I'm looking for a boldness in the post-2015 agenda where we stop talking about child marriage as a harmful practice. It's a development issue. It's the total failure of protecting the rights of adolescent girls. Education, opportunities, valuing the girl, gender inequality. It's not just a harmful practice. Yes, it is abuse of culture and tradition, but it's not just a harmful practice. So my boldness and my call, and thank you to the AU for appointing me the AU Goodwill Ambassador for the campaign to end child marriage. My core is we need a strong target on ending child marriage as a proxy target for adolescent health, because we can address the multiple factors that relate to adolescent health by simply investing in a clear commitment to end within a generation the child marriage that we have. I'm smiling with one eye, really smiling with one eye, because all the reports have shown great progress. I'm still crying with one eye, because I'm still looking for boldness for accountability and for commitment. Thank you very much.
Thank you very much, my sister. Rights, dignity, equity, value, boldness. We are entering an era of sustainable development. We propose a new framework for women and children's health, building on the continuum of care to a cycle of well-being for every woman, every child, every adolescent. So let us all commit now to being held accountable for delivering this. Not holding anyone else accountable, but ourselves. This must be our vision for post-2015. Carol and the PMNCH, under the amazing leadership of Mama Gracia Machel, who sat very quietly, some of you may not have seen her, throughout her proceedings. She only left a few minutes ago, and listened to us. We thank you for giving us this opportunity. But in order to thank everybody else in the appropriate manner, I would like to now hand over to Carol to close this meeting. Thank you.
Thanks. I do say every year we should actually just come clean and call this lunch, because we managed to get you all out on a Sunday morning and keep you here for nearly 3.5 hours. And I think that is a sign of tremendous commitment. And we've been using lots of road analogies. I mean, we do need to build this road together. Amina told us there's a road to 2030, but we need to work back from that and really look at how we're doing that. Do we help or do we hinder? And do we stop countries being, I loved your term, Amina, petri dishes? We've really got to get beyond that. So I do need to thank not a lot of list of people by name, but all our panelists and the participants, the honourable ministers and many others who've sat here and given us their insights and given us loads of food for thought. The co-hosts, Countdown to 2015, the Independent Expert Review Group. I'm not a megaphone, but we had a great one over there. And Family Care International, who did a lot of the local hosting arrangements. Sincere thanks to all of you. The PowerPoints will be on PMNCH.org. There is a video of the session, I believe, as well, which will be up there. Please take the reports outside. There's tremendously rich information in there. They are, of course, all online, but if you're like me, you're not very technically savvy, it's much easier to look at them in hard copy. Has anyone seen the IKEA book ad? I commend it to you, because we've got lots of books out there and they've got lots of great information. So thank you. We'll be talking about these things all week, and I really hope that when we get to the 2015 General Assembly, we have that road clearly delineated. It's not gone to the lowest common denominator, and we really do something very significant for the dignity of women and children. Thank you for that word. Thank you.